Hello, Elias.
Hi, good morning.
Um, how are you? Okay.
Good, how are you?
Oh, very good, thanks. Very good. Excellent. Um, hello, Giles. Let me just get. So,
எனக்கு ഇതൊന്നുണ്ട്.
Rajesh.
Hi, Noren.
Hello. Sir, let me.
Yeah, can you hear me?
Yes, I can hear you. How are you doing? You okay?
Yeah, this is Dr. Chaudhary from Bangladesh.
Absolutely. I know.
Maka,
How are you? You okay?
fine. How are you?
Very well, thanks. Very well. Very well. You in theater today? You are in theater today?
Yeah. Hey, YouTube তো আর শব্দ যাবে না, তাই না? আনমিউট হলে না যাবে।
Morning, Naren.
Morning, Dr. Hbbaoub. How are you, Dr. Hbbaoub? Great, thank you. I shall. How are you, sir?
I'm fine. How are you doing?
Very well, thanks. Very well.
Thank you too. And thanks for putting this together. This is a real, another feather in your cap. So
Thank you, Dr. Hbbaoub. Thanks for the support. But as I will tell in the introduction, you had started this all over 10 years ago, I think, with Dr. Mike Glantz for the AANS and NREF, and then you put the videos on YouTube as well. So I'm just following.
well, I think it's important, and I'm glad you're doing this.
Thanks. I think having an understanding just gives you that confidence, isn't it? When people say stuff, you know that you can, like a judo master, you know that you can tackle it. You're not blinded by it. So I hope.
So I was planning to just share my screen for the few slides I have. Is that okay?
Yes, you should be able to share it now, Dr. Hbbaoub.
Let me just try it, make sure everything looks okay. So do you see the presentation?
Yes, I see.
Okay.
Great. Thanks, thank you.
Looks like you're going to have a pretty good turnout for this.
It should be a good turnout. It's about 170 people registered. Always difficult to make it sometimes, but I'm sure they will later can catch up. Anyone misses it.
So do you remember this guy?
Oh yes. How's Bee doing?
Bee's a young woman now. She's taller than Kim.
Wow, really?
But she's doing very, very well. And she still remembers your visit.
Oh, thank you. 2019, wasn't it? Time flies. Her birthday comes a week after mine, you see. So Hello, Cara.
Hey, how are you doing?
I'm very well, thanks. How are you?
Oh, good.
Hey, Cara.
Hey, how are you, sir?
Not bad. How you doing?
Oh, just fine. I tell you, 1 p.m. UK time is like the perfect time to have a conference.
Yes, isn't
like
it? This is
8 in the morning. It's so great.
especially on Saturday.
Yeah.
Yeah, nothing else going on. This is good. So
Right. That's right.
I think with webinars, the only people who lost out on webinars, I think is the West Coast people in the West Coast, because their time is always, by the time they start, Britain is almost finished and India is in midnight. They have not been as much in webinars. So sometimes where you stay in the world matters.
Yeah, you have to be pretty dedicated to get up at 5 a.m. for a conference on the West Coast on Saturday.
that's character building.
Yeah, that's what we call it for the residents, right?
That's right.
Hello, Mr. Sinha.
Hi, Naren.
How are you, Mr. Sinha? Thanks for joining.
Sorry, I'm informally dressed. I'm at home.
Thanks for joining. Dr. Sinha, can I introduce you to Dr. Harbaugh?
Of course.
And Dr. Harbaugh.
Let's see if I can get my video working.
Dr. Harbaugh is
Hello there.
Hi.
it's one of the giants of American neurosurgery, past president of AANS, past president of Society of Neurosurgeons, but I think the impact that Dr. Harbaugh has had on neurosurgery it's amazing. You wouldn't believe. I think he's probably I have followed American neurosurgery very carefully as much as British and also the history, but I don't think anyone has had such impact on American neurosurgery as an institution as Dr. Harbaugh. So.
Wow, I've read about
That
him.
means I'm old.
Mr. Sinha was my trainer when I did fellowship in pediatric neurosurgery in Liverpool. So, hello, Mr. Sinha. Thanks for joining.
Nice catching with everyone, guys.
Nice to meet you.
Thanks so much for organizing such an important meeting.
Oh,
We all need a bit of brush up on our statistics. I'm just going to mute myself now.
no, thanks. No problem. So let me just do the last checks. Dr. Hbbaoub, I mentioned to Dr. Hbbaoub that you started as a pediatric neurosurgeon and then you got pulled into vascular neurosurgery. I mentioned to him earlier in the week. He said he didn't know about it. He said, thank you.
Yeah, that was my first job. I had, 2 days of research and 3 days as a pediatric neurosurgeon. But then our vascular person left and I got switched. So very different times.
It's amazing because I think in the next year, the president of the EAN and the president of the ISBN and the president of the ESPN, they are all Italian pediatric neurosurgeons. So I said, well, Dr. Hbbaoub is pediatric neurosurgeon here in heart. We have got a few more minutes, then we'll show.
Hi, Naren. Good evening.
Good evening. Hi, Rafael. Hello, Francisco. Hello, Ghaith.
Hi.
Welcome, Ghaith. Thank you for joining us. I really appreciate you being part of
Thank you for having me.
our pressure privilege. Dr. Harbaugh, I know that you mentioned 3 years ago when I mentioned about machine learning, or maybe 4 years ago, you already have a center for AI, and Ghaith from Cleveland is very keen on artificial intelligence as well. That's his area of interest. So Dr. Benzel recommended me I contact him. So good to have him join us. Sorry, Dr. Harbaugh, you might be mute. Beg your pardon. Yeah, that's right.
Yeah. No, I think the AI is going to have a pretty profound effect on medicine, as it will for so many other things. Have you seen the recent stuff for skin screening?
No, I haven't.
Apparently, this is coming out of MIT, but you can just take a photograph, an image of your back, and an AI program that will analyze that and is able to pick up melanoma, at the same rate as a dermatologist. I think all of these image analysis things, whether it's screening for skin cancers or radiology or histology, I suspect AI is going to be able to do it at least as well as skilled clinicians.
I think the ophthalmology apparently also have started using AI to look at the fundi to double check. So I think, even in the last few years, I was shocked that you can create pretty good presentations with AI on PowerPoint. It's in this November, Microsoft produced this Copilot. It just goes and sticks into the Word or Window or PowerPoint, and you just have to press a button, and that's it. So great to have Professor Uwe Keller. He's just the past president of the Hydrocephalus Society. And great to have Marianne from France. She's from Sofisa. Great. I think we are on time. Let's see. Yeah, we are on time. So welcome everyone to this course in medical statistics. The aim of this course is to give you a understanding of the fundamentals of statistics, so then you can pursue understanding further statistics, get the confidence to pursue further statistics. But I'm going to leave the opening remarks to Dr. Harbaugh. And we have got an excellent faculty, and thank you for all coming to this course. And at the end of the course, I will put a link for the feedback form. That's mainly for you to put your name and email address so I can send you the certificates. So it really gives me an immense honor and privilege to introduce Dr. Robert Harbaugh. I have had the privilege of knowing Dr. Harbaugh from 2006. He has been a mentor, probably the main mentor for me since that time. And much of the work I did has always been supported by him, and certainly the affiliate faculty post that he gave me in 2017 has been a game changer. But Dr. Harbaugh is an icon of American neurosurgery, past president of the American Association of Neurosurgeons, and past president of the Society of Neurosurgeons. That's the Society for the Elite Neurosurgeons, older than AANS. More than that, his impact on American neurosurgery is just astounding. I have been a good student of history of American as well as British neurosurgery, but I have not in my study that who has had such impact in American neurosurgery. The ones that I know of, he was one of those people who were instrumental in getting the vascular neurosurgeons dual trained. He was one of the, he was the forefront of bringing American neurosurgery into the digital era, being the chairman of the Digital and Technology Committee of AANS. He was instrumental in setting up the National Registry, which is a huge engine nowadays for American neurosurgery in collecting data and analyzing data. He was instrumental in actually about over 10 years ago now, starting the first statistics boot camp for the residents in neurosurgical residents in America with his colleague, Dr. Michael Glantz, a neuro-oncologist with expertise in medical statistics. And they did this for AANS and NREF, and then they put the videos on the YouTube. One of the first free YouTube videos of courses was from there. That's only a few, and now Dr. Harbaugh is also the head of the accreditation, as I understand it, for the neurosurgery residency programs in America. So I can go on the whole course going through his accomplishments. In terms of internationally, we both collaborated on setting up the International Neurosurgery Residence course that ran since 2016 until the COVID, which was the largest course in the world. And also when he was the president of the AANS, he had a global initiative, had a global neurosurgery office, and also invited all the neurosurgeons from all the societies for a meeting together to see how neurosurgery can be pushed and how American neurosurgery can help the world. So without, I think, as I said, I can go forever, but Dr. Hbbaoub, it's a real privilege to have you. Thank you, sir.
Well, thank you very much for that very kind introduction. As I said earlier, that just means I'm old. You know, if you hang around long enough, you get a lot of jobs. So I want to give some kudos to Naren, not only for this course, but for the enormous effort that he's put into educating neurosurgeons around the world through these in-person and virtual conferences. I mean, it is an enormous amount of work to set something like this up. So thank you, Naren, and thank you for this opportunity. So if I can share my screen, I will do a brief introduction, and then you can move on with the more important work. So can everyone see the slides?
Yes, we can, yeah.
Okay, so this is just going to be a 4-slide introduction to this, I think, very important course. But one of the questions that I've gotten over the years is, I know you think this biostatistics stuff is important, but, you know, neurosurgeons have more pressing issues to deal with. And why is this important for neurosurgeons? And I think to understand that, we really have to step back for a minute and think about how we think and what leads us to draw causal conclusions from our observations. And I think very often we do this through, a heuristic mechanism, a mental shortcut, sort of a rule of thumb strategy. And this allows us to solve problems and make judgments quickly and efficiently. And as you know, in a field like neurosurgery, where often we're faced with situations that need our intervention, we may not have complete data, all the data we'd like to have, but we have to act quickly. And these kind of heuristic strategies really do shorten our decision-making time. And in an emergency situation, we can't wait to say, well, we need every piece of information and we need to analyze it carefully before we intervene. So these heuristic approaches are often very helpful, but they can also lead to pretty significant errors if we apply them all the time. So, you know, here's something I think that is an important thing for us to understand. You know, we are sort of, our brains are built to draw causal inferences from our observations. And I think that ability and the ability to make rapid decisions has had substantial survival value for us. You know, if you're a Cro-Magnon man and you're walking along and see the grass move in a specific way, and you say, boy, the last time I saw the grass move like that, there was a stabbing cat that attacked and killed a member of our group. And so you react immediately to that. Of course, it could be something else making the grass move, but the ability to draw that causal inference from an observation and to make a rapid decision is built into our brains. We do it all the time. Another thing that I think, if you step back and think about it for a minute, is that, we really like a good story. We want to understand things, and there's really nothing as powerful as a good story. A compelling narrative impels belief. And so some things like, well, this person went to the chiropractor and he subsequently had a vertebrobasilar stroke. Therefore, that means that the chiropractic manipulation caused a dissection, which caused a stroke. That's a compelling story. It impels our belief. But then if you actually talk to the patient and he says, well, I had this terrible neck pain. It came on suddenly, and that's why I went to the chiropractor. Well, another option there is, well, maybe the chiropractor didn't cause the dissection and didn't cause the stroke. The dissection is what got the person to the chiropractor. So, that compelling story needs to be investigated thoroughly before you really understand it. And then another piece of this is that once we have our compelling story, once we think we understand something, there's a lot of psychological comfort from confirmation bias. We tend to pick out the data that supports what we already believe and get rid of the data that doesn't. And so these are things that are built into our brains. They're hardwired. They're part of our human psychology. And biostatistics is a way to, counter some of this. So, we do think in two different ways, both of which are very valuable. One is intuitive. It's fast and easy. It's often correct. It's hardwired. And so the picture on the left of the basketball player trying to put the ball in the basket, that has to be intuitive thinking. You don't have time to sit down and calculate just how much force you have to put on the ball, what's the correct arc. That just doesn't work in that situation. So that kind of intuitive thinking is essential to be effective in that environment. And some of the things we do in neurosurgery are exactly like that. We have to be able to make decisions rapidly. But there's another kind of thinking that we do, and that's the kind of thinking that would be required to not put the ball in the basket, but to put a person on the moon. And that's slow, it's effortful, it's more often correct because we look at all of the different options, and it's reason-based. So this difference between intuitive and reflective thinking is, I think, the reason that biostatistics is so important. We want to make sure that we check our intuitive thinking with reflective thinking. And what biostatistics requires us to do is actually reflect on our experience to be able to analyze data in a very rigid and stepwise fashion to bring our reason to bear on situations where we often use our intuitive thinking. And so whether it's reviewing the literature or designing a clinical study or even understanding the things that we think we know, biostatistics, I think, is a really very, very important tool. And again, I thank Naren for setting up what looks to be a really good conference to give neurosurgeons the basics in biostatistics so that we can bring our reflective thinking to bear on many of these important issues in neurosurgery. So thank you for the opportunity for this brief introduction. And I hope everybody has a great time at the conference, and happy to take any questions.
Thank you very much, Dr. Hbbaoub, for that overview of how important medical statistics is. Just to know, in terms of the medical, the residents in states, how much statistics is taught, or they do learn it just during their research time?
Well, at our I think we have a kind of a unique situation. We have a biostatistics based conference every week for 2 hours. It's on Friday from noon to 2. And during that period, we not only have didactic lectures, but we have the residents present, use some of the biostatistical tools you'll see here, report on their research efforts. And it's become, I think a very, very important part of our residency. And I do think our residents finish their residency program knowing more biostatistics than almost any other residents anywhere in the world. And I think you're going to see some of our former residents in this conference, Dr. Brandmeir, Dr. Riz, have really used this biostatistics to advance their career.
Thank you. Thank you very much, Dr. Hbbaoub. We will, if that's okay, we will now go to Dr. Sedney. Most grateful, Dr. Hbbaoub, for.
Thank you very much.
Thank you, sir. Cheers. So now I will introduce Dr. Cara Sedney. It's an immense pleasure. She's a good friend of mine. We met through one of the webinars, and we have now been friends for now probably about 15 years, I should think so. So Dr. Sedney is an associate professor of neurosurgery at the Department of Neurosurgery at University of West Virginia. Her area of interest is clinical area of interest is spine. She also is obviously active, like all American academic neurosurgeons, in research, and also she has extended to qualitative studies as well. We'll have another meeting hopefully, and we can get her to talk on that. But here she's going to talk to us about study designs and level of evidence. Thank you, Dr. Sedney.
Yeah, thanks for having me. I think my very first talk we ever did on one of these online things was like about trigeminal schwannomas or something like 15 years ago. So, well, thanks for letting me be involved in this series of talks. I'm going to start us off with a high-level view of study designs and levels of evidence. And so our objectives are to understand different study designs, understand their strengths and weaknesses, and then apply levels of evidence to these different types of studies. So when we talk about various study designs, we can think of them based on how rigorous they are as being organized like this, with basic science and translational research being at the base of the knowledge pyramid, followed by observational studies like case reports, case control series, cross-sectional and cohort studies. And then we manipulate patient outcomes instead of just observing them in the form of a trial, such as an RCT. And then systematic analyses and meta-analyses are at the very top of the pyramid. So we'll go through all of these general study types, starting with basic science and translational research here at the base. And so basic science and translational research are, of course, experimental, but they form the basis of that knowledge pyramid because it's difficult to directly relate their findings to patient care. However, they're very useful for getting a mechanistic understanding of biological processes or formulating hypotheses using this type of research. And we can also ascertain safety of certain drugs or devices with this type of research. And so in this way, basic science and translational studies really form the basis for all of our further clinical studies. So the next several study types are observational in nature, which means that we are observing and drawing conclusions rather than manipulating something about the care of the patient or the environment. And these study designs have no intervention, and they can be useful for understanding things like rare conditions or exploring preliminary research, since they're relatively quick and inexpensive. And they can allow researchers to understand answers to questions where a trial might be, for instance, prohibitively expensive or time intensive or even unethical. But one of the main disadvantages is that these studies have a number of confounding biases. And so we'll talk about that as we describe levels of evidence. So our first observational set of study designs will be case reports and case series. And case reports generally will have 4 or less patients, and more than 4 patients is often considered a case series. And while these aren't really considered a significant contribution to medical knowledge, they do have an important place in reporting early observations about emerging conditions or in rare conditions. And you might remember that the first appearance of COVID in the literature was early case reports. So there's some value to these case studies in certain circumstances, but in terms of how much they form our clinical practice, it's quite low. Next are case control studies, where a patient with a condition is compared to one without it, which is comparative but still observational. And so in these case control studies, all of them would be retrospective. There are 2 existing groups, one with and one without a disease, and they're compared to identify things like disease risk factors. This type of study attempts to address confounding factors by matching certain characteristics of these cases and controls in order to elevate the strength of the conclusions above a simple case series. And this can be an efficient design and is also feasible for rare outcomes or diseases. However, your conclusions are limited by comparing the 2 groups, so your results are also limited. And certain types of bias can be difficult to avoid in this study type. For example, selection bias occurs if there are differences between the cases and controls that aren't recognized that may be relevant, and recall bias can occur since these are retrospective and depend on recall of events or exposures. Next, we'll discuss cross-sectional studies, which analyze population data at a particular point in time. So cross-sectional studies are those in which population data are collected at a specific point in time with simultaneous measurement of both the exposure and the outcome. And this is a good design for diagnostic studies and that sort of thing. However, these types of studies, which often can include, for example, survey-based studies, are prone to particular types of bias, such as non-response bias in survey studies. And additionally, although you're looking at this, because you're looking at this at a point in time, you can't ascertain causality because you're looking at them at the exact same time. So you can only determine association. Next, we have cohort studies, which are going to longitudinally study a specific population of patients over time. So cohort studies can be either prospective or retrospective, and they identify a specific patient population in which a subset of individuals has experienced a particular exposure or disease, and then compare the rates of disease development or particular outcomes in exposed versus unexposed individuals over time. This is a good design when studying outcomes which are common or for exposures or conditions which are rare. You can measure multiple outcomes in a cohort study, which is useful. You can also get some understanding of time courses of diseases or outcomes. However, like other observational studies, cohort studies are prone to various biases, which may impact the results. While measured confounders can be addressed statistically sometimes, unmeasured or unrecognized confounders can still exist. Attrition and surveillance bias are relevant in this study type, and so good follow-up of patients is key. Additionally, prospective cohort studies specifically can be very time-consuming and expensive as you're following a specific population over time, which can often be years. Next, we're leaving the observational study designs and starting to actually manipulate patient outcomes through a trial. And so ideally, that would be a randomized control trial or an RCT. RCTs are prospective studies that evaluate the effectiveness of interventions through comparison with a placebo or the existing standard of care. Eligible participants are enrolled and then randomly allocated to a treatment arm or a comparison arm. In some RCTs, the patients and even maybe the study personnel can be blinded to the assigned group. The RCT is considered the best study design to evaluate comparative interventions and really the only study type able to strongly establish causation as opposed to association. Although observational studies are limited by the investigator's abilities to adjust for those unmeasured participant characteristics, a well-conducted RCT provides a way to reduce selection and confounding biases by leveraging random allocation of participants to balance both observed and unobserved participant characteristics. And blinding is another strategy is thought to improve validity of the trial, and that's only possible, of course, in a prospective study. Additionally, in RCTs, the research team has better control over the intervention under evaluation with regard to variables such as timing, for instance, or surgical technique variations. The summative result of these different design strengths is a study with higher internal validity that can often be achieved with an observational study, although these studies are still resource and time intensive, and some forms of bias can still occur in RCTs. In general, if a randomized controlled trial is of low quality, it's either because it has poor internal validity due to bias or poor external validity due to lack of generalizability. And it's also important to note that randomized controlled trials are not monolithic. There are many different kinds that can be conducted depending on multiple factors. So the involvement of a good trialist in setting these up can't be understated, things like cluster randomization and that sort of thing. And while surgical trials are very difficult to conduct and conduct well, there are some landmark studies, of course, such as this one that have been conducted and changed the field of neurosurgery. Systematic and meta-analyses are at the top of the pyramid, and they represent a synthesis of available knowledge from all other types of research. And the goal of systematic reviews is to produce an answer to a clinical question on the basis of the synthesis of other available evidence from multiple distinct studies. Systematic reviews can focus on any type of research question, whether related to diagnosis, treatment, prognosis, or education. And these types of studies differ from narrative reviews, which seek to describe previously published works on a specific topic, but they usually don't have systematic methods, for instance, to determine study eligibility of what they're going to include in their paper, or performing a comprehensive search strategy that they are outlining in the paper, or appraise studies for bias. Meta-analyses additionally involve a quantitative statistical process that combines numerical outcome data from numerous other studies as if they were the result of a single larger study. The methods of these types of studies involve formulation of a clinical question, determination of study conclusion and exclusion criteria in a systematic fashion, then a comprehensive literature search, appraisal of bias, then determination of the quality of the evidence for each outcome, and then quantitatively or qualitatively synthesizing that data to get a conclusion. The quality of evidence for each outcome across studies is often determined based upon the initial quality of study design and the bias in those initial studies. Systematic reviews and meta-analyses potentially offer the highest quality evidence because of the rigorous methods and broad utilization of study results. But when the quality of included studies is low, you often still need further studies to address the clinical question. Another thing to note is that heterogeneity, either clinical or statistical, can limit the utility of these measures. If the studies are very different, they can't be compared. So as we've walked through these study types, it should be evident that not only is there a hierarchical organization in terms of the quality of these different types of studies, but also studies within each study type can be done well or poorly in terms of their design or how they address the different forms of bias. So I like this conceptualization of study types by Murad and colleagues. This shows that some high quality observational studies, for example, might be superior to poorly done randomized trials. And you can also see that they've separated out systematic reviews and meta-analyses here in the sense that they aren't generating new knowledge so much as synthesizing other study types. So if there's variation in study quality within study types, how do we assess that? Assessment of study quality depends upon the design and study aim. In other words, is the research question a therapeutic question, a diagnostic question, prognostic, or decision analysis question? And depending upon which of those four it is, there are specific quality indicators. And that's probably beyond the scope of this talk, but in general, assessment of study design and execution depends upon how they handle bias. For example, a selection bias, which is systematic differences between the two groups being compared. This can be avoided by randomization as long as your group allocation is randomly assigned by a predefined process such as sequence generation, and if the allocations aren't known beforehand, which is called allocation concealment. We also have performance bias, which is systematic differences in the care or exposure of patients. You can avoid this by blinding sometimes, but not always possible for surgical trials. You can have attrition bias, which is systematic differences in withdrawal from the study. So if there's significant departure from the treatment group and you end up doing an as treated analysis, or if your missing outcome data is more frequent in one group than in another, your study would be at high risk of attrition bias. You can avoid this to some extent by limiting loss to follow-up. Then you have detection bias. That's systematic differences in how outcomes are determined. Again, that can be avoided by appropriate blinding, particularly of the outcomes assessors in studies. And then reporting bias. And that would be systematic differences between reported and unreported findings, which would skew the results towards significance. And that can be avoided by predetermining and stating ahead of time what your primary and secondary outcomes are, and then actually reporting all of those pre-specified outcomes regardless of significance. Imprecision is another factor that impacts study quality. For example, if your study group that you have recruited differs in significant ways from the general population of interest, or if there are technique or measurement variabilities in your study protocol that impacts the validity or the precision. Other quality indicators, particularly for clinical trials, can be very granular. So for example, how did they do their sequence generation? Did they do something completely random, like a random number generator or a coin toss, or is it something tied to some element which isn't random, like allocation based upon the day of the week? So patients that come in on Tuesday are not quite the same as patients that come in on Friday. Then another question can be, did they conduct their allocation concealment to minimize selection bias? For example, were patients allocated to their treatment group by central allocation, or were they alternatively allocated in some way the researchers could predict, like alternation or date of birth? If they know that the odd number date of births go to one group and the even number date of births go to another group, then the researchers can predict which patient's going to go where. And then was blinding done? Were both participants and personnel blinded? Obviously difficult to do with surgical trials, but that would be the ideal. And then lastly, were data and outcomes completely reported, or were they only the data supporting the hypothesis were reported? So those are the kind of ways that you assess quality, and particularly in an RCT. So when you assess and rank these study types on the basis of quality, you get a new organization of scientific knowledge, which is levels of evidence. And you can see here that the pyramid for levels of evidence is heavily dependent upon study type. So this looks very similar to the previous diagram that we looked at. But there is crossover similar to in Murad's study design pyramid, where, for example, poorly done observational studies are similar to case studies. And lesser quality RCTs may be similar in strength of evidence to prospective comparative trials or even retrospective studies. And then the best quality of evidence consists of well-conducted RCTs and meta-analyses. And as I mentioned, criteria for what specifically fits the levels of evidence depends upon the aim of the study. And you can see here the NAS guidelines. NAS is a spine society very active in guidelines creation. And in order to create guidelines, you have to have a systematic way to evaluate literature. And so this is theirs. Maybe a bit dated. This is the only one I could find, but you can see it's from 2005. And you can see there are different criteria for the different types of studies: therapeutic, prognostic, diagnostic, and economic studies. And you can see that for the therapeutic studies, level 1 evidence here includes high quality randomized trials, because we are manipulating the therapy here and establishing causation. But for example, in prognostic studies, prospective studies with good enrollment are considered level 1 by NAS. But there's also very specific criteria to fit studies into these categories relating to quality because of that heterogeneity in what people call their studies. So for example, it's stipulated here that for prospective studies, they have to be initiated before that first patient is enrolled. If it's not done that way, it's retrospective. And so we've talked a lot about evaluating literature, which is of course important, but presumably some of the attendees to this course might want to conduct their own research. And so I think it's important to touch on how we would choose a study type for the research we want to conduct. That is going to be dependent on a number of factors, some based upon the scientific components and some more practical components. An important caveat, though, is that this is just a brief overview. And so prior to initiating a study, collaboration with research methodologists and statisticians and more experienced researchers is definitely needed to make sure that a study is successful and feasible. With that said, you first need to identify if your research is hypothesis-driven or if it's exploratory or descriptive. If you have a specific research question, you should also have a hypothesis, which most biomedical research should be hypothesis-driven. And so that means you'll most likely be conducting quantitative research rather than qualitative research, which is different and less used in biomedical research. And then you'll have need to have a grasp of what you're studying and the type of research question that you're asking. Basically, the breakdown that we've been talking about, are you asking a question about disease prognosis or disease treatment or disease diagnosis? Because that will drive the type of study you might ideally pick. Next, you need to think about practical questions, like how much time do you feasibly have to conduct a study? As we mentioned, a prospective cohort study might be best for studying disease incidence, but if you're a trainee and don't have the ability to conduct a multi-year prospective study, something cross-sectional might be more feasible for you, even if it's not the ideal study type for the research question. Similarly, prospective studies and trials are very expensive, and so doing them without funding, whether grant funding or industry funding, would be very difficult. But in order to get funding, you generally have to have some established expertise in the diagnosis you're studying and the methodology you're proposing. And so that might be that lower level types of studies, including even practical expertise, such as a track record of patient enrollment in studies. And then the expertise piece is just one component of feasibility that needs to be established, for any sort of study, really, especially ones you're seeking funding for. For example, if you're wanting to do an RCT of a very rare disorder, it's likely not feasible unless you are in a very specific research location and you see lots of these types of patients, and that's very well established to funders. So in summary, there are specific study types depending on the type of research question being asked, and depending on that research question, different ones might be the ideal. Study types, as well as how we manage bias and other quality indicators, can determine the study's level of evidence. And lastly, planning for a study involves scientific and pragmatic considerations to determine the optimal study type. And that's the end of my talk.
Thank you very much, Dr. Sedney. That's a fantastic overview of the study designs, and importantly, as importantly, that you highlighted that the level of evidence doesn't necessarily depend on what the study or what category of study it was, and the idea that all RCTs are not the same is really useful to know. And before looking at what the results of the RCT, once again, very carefully looking to see how good an RCT it is. Just one question from me is that with the registries that are being increasingly done, where do the registries, if I had missed it, I'm sorry, where do the registries fit into this hierarchy of studies?
Yeah, that's a really good question. So I think certainly Dr. Harbaugh probably has strong feelings on this, but essentially, the idea with registries is that if your methodology is good and your numbers are big enough, it tries to edge toward establishing causation without doing a trial, because of course surgical trials are very difficult to do and do well, and very expensive and sometimes not ethical. And so for things like surgery, very large registries, established registries with a specific and excellent enrollment may be very useful, but we still have some confounding biases. One thing that is relevant for our place is that patients that are enrolled in registries are not necessarily representative of the entire population. So for example, in our population, very socioeconomically deprived area, we don't currently pay the $20,000 or whatever to enroll in some of these registries. And so our patients are not represented. And so there are still confounders, but certainly the idea is to sort of edge up against that level of evidence of a randomized controlled trial with methodology and numbers.
Thanks. The second question is that it's always said that when you are starting studies, get a medical statistician, sit down with a medical statistician to go and plan the study beforehand. But sometimes not possible. Not all the departments have that kind of facility. What's your thoughts on that? Thanks.
So I think it's good to have a friend with statistics knowledge. So I'm not a biostatistics guru, but I know some, and one of them being Nick Brandmeir. And so having a friend or colleague that has that knowledge, whether it's at your institution or some other place, can be very, very useful. And so, if we're smart, we talk about it before I collect the data. If I'm not as smart, I'll give him the data after I've already collected it and just see, what they can do with it.
Thank you. I think it's always worth checking it with second person, because you don't want to finish the study and then figure out that you should have had made the changes beforehand. And the listserv actually has a statistical center. If any of you want to send your proposals for one of our senior neurosurgeons with the statistical knowledge look at it, then you can send it to us. That was established now about 10 years ago. So if there's any further questions to Dr. Cara Sedney, could you please put it on the chat group? And Cara, are you happy for any of the delegates later on to contact you as well if they have any questions about studies? Thanks.
Yeah, absolutely. There was one question about systematic review, and I'll just put the link to the Prisma guidelines in the chat if that works.
Oh, brilliant. Thank you. Thank you very much, Cara. So now I'll go to my talk. Let me see whether I can just get it. So many windows open. So can you see screens saying statistics made easy? That's great. Thanks. So I'm going to take you through the basics of statistics that as I see it. I think once you have a firm grasp of the basics, the simple things, it's actually quite easy to build upon it. And particularly nowadays that there's so much information on the web and YouTube. So I just want to get you to the basics that many people usually think that they know, or many people don't get taught. So we will start with these are the things, some of the things that I'm going to cover. So the important thing, first of all, to understand that the statistics works because there are usually an underlying pattern to the data. Most biological data have a normal distribution, but there are several other distribution, Poisson's distribution, exponential distribution like in COVID, or binomial distribution as in flipping a coin. So there are so many different distributions, but the predominant distribution in medicine is normal distribution or Gaussian distribution. So all this, the statistics tests that you see are usually either based on the normal distribution, or when it's parametric, then they use a different distribution. So that's where the fundamental of the magic of statistics comes from an underlying mathematical relations in the data. Once again, the next important thing is that to understand that what are the types of variables. I'm keeping it simple here. So the categorical one is, color or gender or social status or which country people are from. So they are all categorical. And continuous is height, weight, anything that you can measure is a continuous variable. And ordinal variable is, so Glasgow Coma scale is actually not a continuous variable, it's an ordinal variable. The main reason is that when you go from, let's say, GCS from 7 to 8 and from 12 to 13, they are two different jumps. So they are called ordinal. They have been organized in a ranking system, but they are not continuous. So there's always a controversy whether you can ever do mean on GCS because it's ordinal. Some people do it, but technically you can't do. You have to do median on GCS. But always in statistics, like many things in life, there's always people argue that you can still do mean, but on the whole, to be safe, just do median on GCS. So the other thing about statistics is that to understand that statistics is about trying to draw conclusion for the population from a sample. If we had the data of the whole population, then we really don't need statistics as such. So if we have the results of, in our end of high school exam before we go to university school, A level or advanced level, and obviously the government has results on every single kid who takes A level exam. So they have got the whole population results. So when they have the population results like that, you don't need to do so much statistics. You can just tabulate. But so what are the thing that we usually do statistics is for the things that we don't have the population, we only have a sample, and then we do the statistics on the sample and then try to extrapolate what would be the population results is. So let's say the one of the sample is class. Now, if you have a class and if you want to know what's the average height of a class, children in the 4th year of the school, then you have only a class and then you measure their height and then you use statistics to know what the population's height might be. So as I said earlier, if you have the results of the whole population, then there's less reason for statistics. In terms of the relationship between population and sample. So if the whole of the country is school and then we have a class, what we assume when we do statistics on a sample is that those sample have been drawn randomly from the population. So that's one of the main assumption when we do statistics. You can't go and do measure the height of children in a extremely wealthy area or in an extremely deprived area and then try to decide what's the height in the population of the whole of the country. And once you have decided so because of this random assumption of randomness, then you measure the height in your class and then you decide for the whole population. So this is how the statistics mainly that we do is for the sample. The other important fundamental thing is to know the center of the data, the central tendency, because when we collect data, as you know, it's all over the place. But it's very hard to get all of that idea in one way. One way is to try to see whether there's a central tendency that you can identify. It's a central tendency is similar to having a center of gravity. So when everything is nice and symmetrical block, you can put the pivot on the middle and it nicely balances. But when the shape is not so regular, then you have to adjust where the pivot is. In the same way, finding the central tendency is not that easy when there's such variability. So when I say what is the central tendency, what is this, that when we have a lot of results, for us to make some sort of meaning, we want to know what's the typical or what's representative. That's the central tendency. So one of the parameters of central tendency is mode. Mode is basically the most frequently occurring response. So mode can be in a continuous variable like numbers, let's say 5, 7. Here, the most commonly occurring is 9. So the mode is 9. But once again, while it gives you a kind of central tendency, it doesn't exactly represent the whole number so well. And also mode, if it's a categorical variables, if you say who's attending these courses, and if I tabulate it, and if it was neurosurgical trainees who are attending most, then the mode, which is the highest frequency, will be the neurosurgical trainees. The other parameters of a central tendency is mean and median. Mean, as you all know, is the average. It's also called arithmetic mean, and where you take the sum and then divide it by the total number. Mean usually is used when the distribution is a normal distribution. When the distribution is skewed, that we'll look soon, then we look at median. And the median is basically the middle number when you line up, when you arrange your data from the minimum to the maximum. So if the distribution of the data is normal distribution, then the mode, which is the most frequently occurring item, the mean and the median, they are all at the same point. But if the data is skewed, then things start to go, and you will see that they differ. So this is a negatively skewed, where the tail is going to the left. This is the normal distribution, and this is a positively skews, the tail is going to the right. So here there are few people who have large numbers. So if you look at let's say if you look at people's earning, then if you look at people's earning, then you will see one or two people who are billionaires. So they will be skewing the graph to the right side. If you look at the exam scores in a class, most of the kids will be hitting around 50, 60, 70. Some of them will be hitting higher scores, and the rest will be there will be a long tail of someone going from 10, 25, 35, 40, but their frequency will be small, but it will be pulled out. So this is a negative skew. This is a positive skew when someone is a billionaire in geomist, and this is the normal. So what happens when they are skewed, and what happens the mean to the mode, median, and mean? Because we said that earlier, in normal distribution, they are all at the same point. When there's a skewed distribution, once again, whichever is the summit, that's still the mode. But you see, a tail to the left pulls the mean further away from the mode and from the median. So it's coming towards the tail. And certainly the median is also pulled, but it's not so much as pulled or influenced by the tail as the mean. And when the skew is positive, once again, the mean, median, and mode are now separated. The mean is pulled towards the right-sided tail. So the billionaire, his money will pull you mean further down, further up the earnings, whereas median is a bit more representative and mode stays there. So this is how, so it's always nice to know in a data what's the mean, median, and mode. That gives you a better idea rather than just having one parameter if the data is not a normal distribution. And standard deviation, you will all come across standard deviation reported. That is to explain to you, give you an idea of how well is the data spread. Here you can see two normal distribution of the same amount of subjects. Here you can see the red one where the spread is very narrow, whereas here in the blue one the spread is much spread out. And so that's where the standard deviation tells you how much the spread of the data is. If the data falls within the first standard deviation from either side, then that usually accounts for about 60% of the data points. And if the data is within two standard deviations, then that accounts for 95% of the data. And another thing that you will often come across is called standard error of mean. And the standard error of mean, just a second, I'll just stop my phone making noise. The standard error of mean is similar, once again, I'll explain to you. Usually means are calculated for a sample. So when we say the average height in a class, when we are calculating the mean for that class. But what we really want to know is what's the mean going to be if we looked at all the children in the country, and so the standard error of mean gives you an idea about the true mean for the whole population. So standard deviation is about that sample, that class, and how well the data is spread within the class. Whereas the standard error of mean is you are trying to figure out what's likely to be the population mean from the mean in your class. So the next slide will explain to you. So when we do the mean of a class, and then if we go around the whole country and do mean height of every class, then we will have so many means. And then, so let's say that if we then tabulate all the means height of all the children in all the schools in the whole of the country, then we'll have a long table. And then Then what we do is that if we plot that mean and say what against the number. So for example, if let's say this is the height is 5 foot, and here this number will be like, let's say 200,000 children have a height of 5 foot, and then as the height goes down, they get lesser and lesser numbers. As the height goes up, less and less. So, but this is here I'm not plotting the height. Here I'm plotting the means from every school. And so the standard error of mean is basically, the standard deviation of this graph, of this. So that's what we are trying to figure out. That standard error of mean gives you an idea of what's likely to be the mean. Now that you have a mean in your class, what's likely to be the range of the mean, 68% likely of the population mean. So let's have a look. So once again, here the standard deviation in a class, that shows the spread within the class. But if you are looking at the standard error of mean, plus or minus, when we put with our mean, it says that the population mean is likely to be in that range. And now we will come to confidence interval. Confidence interval is very important when the results are quoted. That basically gives us an idea what's the likely chance that the 95%, if we set the confidence interval to be 95, what it says is that the mean in the country is likely to be 95% chance the mean height is going to be within this range. Whereas the standard error of mean was 68% of the mean. The confidence interval is usually plus or minus 2 standard standard error of mean. So that's where your confidence interval comes from, standard error of means. So when you look at studies, you will always see error bars. Be careful what they mean, because the error bars can mislead you. If the error bars are just standard deviation, whether these error bars cross each other really doesn't matter, because the standard deviation only gives you an idea about this particular data. It doesn't give you any more information. It talks about the spread of that particular data. Standard error of the mean, once again, gives you an idea where the range of the mean should be. Once again, they don't crossing them, these bars crossing or not crossing doesn't say whether they are significantly different or not. But if the error bar that they have put in the study is 95% confidence interval, then if they cross each other, then you know that there's not significant difference between the two groups. And if they don't cross as in here, then you know that the data shows that there's a significant difference between the two groups. Once again, in rare circumstances, you can have exceptions where the 95 confidence interval don't cross each other, but the study is still significant. But as a general rule, if the error bar is 95% confidence interval and the bars don't cross, then you know there's a significant difference between the two studies. So now let's look at some other common statistics that you usually come across. These are the things that I'm going to take you through. So one of the common things that you come across is when you have a test, you want to know how accurate the test is. So this is where this is the disease and no disease. If you have a gold standard to look at the disease, then the columns will be disease and no disease, and on the row you put the outcome of the test, whether the test was positive or the test was negative. So this point where the disease and the test is positive, we call it the true positives. When there's no disease and the test is negative, we call it the true negatives. And when there's a disease but the test is negative, we call it false negative. And when there's no disease but the test is positive for it. We call it false positive. This trying to figure out sensitivity and specificity is the most common statistics that you will come across. The sensitivity is how good is the test in picking up the patients with the disease. So sensitivity is usually easy for everyone to figure out. That's basically that's people who have disease that have been picked up as having disease divided by all the patients with the disease. So that's easy. The specificity is a bit more difficult to relate to. That's how well is the study in picking up all the negatives. So the true negative is this one, no disease, and test is negative. But all of them are negative. So this one, specificity, is D divided by C plus D. So in terms of when something is low sensitivity, then that test doesn't catch all the true positives. And when something is low specificity, then it doesn't catch all the true negatives. So let's have a look at lumbar puncture for subarachnoid hemorrhage. Once again, I am assuming here that we are just doing lumbar puncture and then sending the CSF for microscopy. I'm not talking about any spectroscopy here. So if you look at the lumbar puncture in a patient suspected with subarachnoid hemorrhage, what we will find is that, so this is patients with real subarachnoid hemorrhage. This is patient with headaches but really don't have subarachnoid hemorrhage. This is when you do a lumbar puncture that the CSF is blood stained. This is where the lumbar puncture, the CSF is clear. So usually when patients have subarachnoid hemorrhage, most of them have blood-stained CSF. Very, very rarely you still can have patients who have, there's no blood in the CSF, but that's very rare. So here the true positive is very high, and the false negative is small. And so here the sensitivity is A divided by A plus B, and lumbar puncture is good in terms of its sensitivity. But the problem is, as you will see soon, is that it doesn't have a, in terms of predicting whether the patient has had subarachnoid hemorrhage or not, it's not so great because it has low positive predictive value. Because if a patient had a lumbar puncture and it was a traumatic lumbar puncture, and even patients who haven't had subarachnoid hemorrhage, many of them will have blood-stained CSF. So if you look at all the patients who have blood-stained CSF and see how many of them actually have subarachnoid hemorrhage, then what you see is that A divided by A plus C, here you will see that the lumbar puncture has low positive predictive value. So although lumbar puncture is good at picking all the patients with subarachnoid hemorrhage, it also picks patients who don't have subarachnoid hemorrhage because of the traumatic tap. So what happens when the lumbar puncture is negative? When the lumbar puncture is negative, then most likely that the patient doesn't have subarachnoid hemorrhage. But as I said earlier, that there are going to be patients who don't have subarachnoid hemorrhage who are going to have a traumatic tap. So when we have, so there should be a specificity, beg your pardon. So the specificity here is that all the true negatives divided by all the negatives. And what you will find is that because that you have had so many patients with traumatic tap, it's not a specific, it's not highly specific, the lumbar puncture. And when the lumbar puncture is negative, it has high negative predictive value. So what I mean by that is that if you have here, if you look at this column, where the patient, all the patients who don't have subarachnoid hemorrhage, they will be negative. Only very few patients who have subarachnoid hemorrhage are going to be have a negative lumbar puncture. So if you look at the negative predictive value, so D divided by D plus B, then you see that the lumbar puncture has a high predictive value. So where the lumbar puncture is most useful in itself is when the test is negative. And this is what I'm saying. So most useful where lumbar puncture is when it is negative. However, you can't rely on lumbar puncture because it's not accurate. Because once again, as I said earlier, it's not 100% negative predictive value. So in one of the things that when you are studying that you will come across is a common mention is that the test has high sensitivity but low specificity. Once again, when people say high sensitivity, it's very easy to understand. You know that most of the disease is going to be picked up. When it says low specificity, it's very difficult to relate. What it means is that when there's low specificity, so that's where there's a lot of false positives. Sorry. When there's lots of false positives, what you are going to have is the positive predictive value is going to be low, because a low sensitivity test is going to have a high false positives. If you look at the positive predictive value, which looks at the true positives and the false positives, because of the high false positive, the positive predictive value is low. So when you have a study that says high sensitivity, low specificity, tell yourself it is highly sensitive. It picks up all the patients with most of the patients with diseases, but it has got a low positive predictive value, because not all the patients who are positive have the disease, because there are many patients who don't have the disease come positive as well. So every time you see specificity, don't try to figure out what it means. Think of it as it has got a low positive predictive value. So what is accuracy? So in this 2x2 data box, you see there are only two places where things are true. Here, this is where the disease is, patient has disease and the test is positive. Here, the patient doesn't have disease and the test is negative. So these are the true negatives and true positives. So these are where the patients have been correctly identified. So that's A and D. And this is the total patients, which is A, B, C, and D. So the accuracy, if you want to know accuracy of a test, it's where A plus D divided by the total. So when a test is 100% specific and 100% sensitive, when the test is 100% sensitive and 100% specific, it's 100% accurate as well. The other important concept that you often come across is the numbers needed to treat. You will have seen that in many studies, particularly in randomized control studies. So numbers needed to treat is basically how many patients you have to treat. So if you have two ways of managing, coiling and clipping, how many patients you have to treat with coiling before one patient has a better outcome? So we'll just look at that. So if you look at that ISET trial from 2005, the complication rate from the coil embolization was 24% and the clip was 31%. So the absolute risk reduction was 7%. So what it means is that if you had 100 patients, then 7 would have had better outcome with coiling. So if 7 patients do better out of 100, so for one patient to do better with the coiling, it will be 100 divided by 7. That will be 14. So you have to treat 14 patients with coiling to get one patient have a better outcome than clipping. That's the numbers needed to treat. And now we come to the important concept of p-value. P stands for probability, and it always comes. So in inferential statistics, that's where we infer. That's the statistics that we consider as medical statistics. what the p-value says is, what's the chance that the difference that you see between the two means are by accident, by chance. So if, let's say, if a p-value is 0.03, what you are saying is that the difference that you see between the two groups might have occurred by chance in 3% of the time. So by convention, we set the significance level to 0.05 of 5%, and we call that alpha. So we say if the chance of the difference occurring by chance is less than 5%, then we will say it is statistically significant. So P is basically a probability, and we set which probability, below which probability that it's the study we are going to consider it as significant. So statistically significant does not mean it's definitely significant. It's just statistically significant, and we presume that it's most likely clinically significant as well. And we are coming to the last few slides. So now the types of errors, these are also very important concepts. Dr. Sedney mentioned that whenever you start a study, you have to have a hypothesis. The null hypothesis is there's no difference between the two groups. So if you look at the ISAT study, what we are saying, the null hypothesis that the outcome from clipping and coiling, there's no difference. But then we found out that the difference had a p-value less than 0.05. So then we ascribed that there's a clinically significant difference between the two groups. But because the p-value was less than 0.05, we ascribed there's a statistical significance and assumed there's a clinical significance. But obviously, we are saying that this could happen less than 5% through chance. But sometimes, things happen by chance. Someone does win the lottery. So although we think for all good and purposes, because the chance of it occurring is less than 5%, we think it's significant, but there's always a small chance, it's not actually truly significant. This still occurred by that 3% chance. So that kind of error, the difference has been ascribed when in reality there's no difference. That's called the type 1 error. Type 2 error is that there's no difference has been ascribed when there is a difference. Let's say that when we looked at the rescue ICP study, we said that there was no statistical significant difference between the medically treated patients and the patients with decompressive craniectomy because the p-value was greater than 0.05. So there we ascribed that there is no difference. But if there is a true difference, and if the study hadn't picked it up, then what we are looking at is a type 2 error. So this is where the null hypothesis, type 1 error and type 2. So every study has a risk of type 1 error and type 2 error depending on how you have ascribed based on the p-value. I hope you have figured it out. Once again, my presentation, I'll put it on the web so you can go through it, because these things sometimes you have to go through on your own to get your head around. Okay, now I'll come to risks. Once again, this is something you will commonly come across, risks. When you're talking about risks, if let's say that 100 people went skiing and one person has an accident, then you will say that, and you will say, what's the risk? If someone says, what's the risk of having an accident when you ski? And if you have the data that one person usually has an accident in every 100, then you put the event, which is 1, the total 100, and you say the risk is 0.01. So it's a probability. And let's say that if someone goes in an e-scooter, sorry, this is, and if 100 people drive the e-scooter and 2 have accidents, then what's the risk? Once again, 2 divided by 100, that's 0.02 or 2%. So that's what we call a risk. So here I have tabulated the risk. Skiing is 0.1. Sorry, it should be 0.01, beg your pardon. Okay. And sorry, am I right? Yeah, it should be 0, beg your pardon. It should be 0.01, and the e-scooter is 0.02. So we have got the risk for both of them. So now what we want to know is that what's the relative risk of driving an e-scooter compared to the skiing. Here we have to put the risk of the e-scooter, which is 0.02, divided by the risk of skiing, which is 0.01, and that gives you a relative risk of 2. So what it says is that the risk of getting an accident from e-scooter is twice as the risk of skiing. So relative risk is intuitive. You can understand what it means. But another concept that's often quoted is odds. Odds, as you will see, is different from risk. Similar but different, and definitely different. So once again, if we say that if this is for me, if I skate 5 times, then I'm going to fall once. The risk of me falling is 1 divided by 5, that's 0.2. But the odd is not 0.2. Odd is basically because it's the number of times I fall divided by the number of times I don't fall, not the total, which is in risk. So here the odd is of me falling is 0.25. So whereas it's easier to figure out what it means when it's a risk, it's a probability. I have 1 in 5 chance of falling. Odd is difficult to figure out what it means. So it's not so intuitive. So if you look at the odds for e-scooter, once again, if I fall, so this is, sorry, it's me. So if this is for e-scooter, if I say that with the e-scooter I fall once every 10 times I ride, then my risk is 0.1 or 10% risk of me falling. But once again, the odd is then the times that I don't fall, that's 1. So that's the times that I do fall, 1 divided by the times that I don't fall. So here the odd is 0.11. So you see how it's different. And so there's a difference between a risk ratio and odds ratio, is that for risk ratio, you put the risk of the skiing divided by the risk of the e-scooter, which gives you a twice as risky of skiing than e-scooter. Whereas if you look at the odds ratio, you put the odds of the skiing divided by the odds of the e-scooter, and that gives you a number which you can't easily interpret. So what I'm trying to say is that whereas relative risk is easy to understand, but odds and odds ratios are not easy to apply. But where odd ratio comes important is that when you are doing case control study, you can't use relative risk. You have to use odds. And also when you are doing logistic regression, one of the output it gives is odd ratios, and then you use that to figure out what each factor, how each factor influences the outcome. So that's why you have to know about the odds ratio. And this is a quote from the paper by Davis et al. Is that when the odds and the risks are low, less than 20%, the odds will approximate to risks, and the odd ratio will approximate to relative risk. Some people say 10, some people here in this paper it says 20%. So what I'm trying to say is that if you are working on relative risk, it's easy to understand, easy to interpret. When it's odds and odd ratios, unless the numbers are small, you can't easily understand, and you can't easily treat it as a relative risk. But if it's less than 20%, you can say this is the odds ratio is 10, and then treat it as if it were a relative risk and say the risk is 10% more. This is, I think, the last couple of slides. It's power. When you are doing randomized control studies, you will find that they will always quote power. For Stitch 2 trial from Professor Mendelow's work, the power was 80%. The power is essentially a flip of the alphas, a significant level. So what the power says is that if it says the power is 80%, what it says that if there's a real difference, there was 80% chance the study would demonstrate this. Conversely, if there was a real difference, then there's a 20% chance that the study would not demonstrate the difference. So you see, so it's important to understand what the power is, because if the power is 80, then you have to understand that the outcome of the study has a 20% chance that it can miss out a real difference. So that's all the basic statistics. But as you know, we can't all do statistics like a statistician, and it's a long way as well. And it's useful. Most of us do statistics using statistics software. I usually give the analogy that we all drive cars, but we don't exactly know the mechanics of the car, but we are very good at getting the car from A to B. But if you are going to be a master car person, then you are driving through the desert, then you better be a very good driver as well as know everything about the car. That's what a statistician is. But we are like a normal car drivers. We just use the car and we can use it very well. In the same way, if you really want statistics, of course, you need to get a professional statistician. But it's nice, it's good to know, have an insight into how to do statistical tests, so you can think statistically, you can plan projects, and you can also interpret studies. So I'm just going to go through the statistical softwares and tell you which ones are useful, which ones are easy, expensive, etc. So, with the MS Excel, you can do more statistical tests. It might take you time, but you can do it. Obviously, everyone pretty much has Excel there. There's something called a statistical add-on that you can actually custom add it. I will send you the link for it. It's that custom add-in only gives you, it does allow most of the basic statistics to be done, but for more deeper statistics, you have to kind of use the Excel to do the calculations. But basically anything that you can, any statistics you can do in Excel, and there are books called dummy series of Excel, how to do statistics on Excel if you want to use it. And as I said, I have put a YouTube video so many years ago, more than 10 years ago, how to add the statistical tool pack. It comes with your Excel, but it's not there from the beginning. You have to go and activate it. Then the other free software is called R. You probably have heard of it. It's very comprehensive. It's complex. There's nothing better than that. But you need to write code. These are not really that difficult codes. But I have to say, I have got the R. I don't really bother. I know that my colleagues, a number of colleagues who have used R, but sometimes it's easier to use a user-friendly software and get the things done rather than write codes. There's another software called SOFA. One of my colleagues, when I was in Royal London, he used to use it. It's free. You can use most of the common statistics. I haven't found it particularly friendly, but it's actually quite friendly, but easy to use. But you just have to invest about 10 or 20 minutes just to understand how to put the data, then it should be okay. So far it's good. The one that I like, I got about 6 months ago, is DataTab. It's an online statistical software from a German company, beautifully done, easy to access. You can have this software wherever you have internet access. You can also download the desktop version as well. The price is good, around $100, $99 for 3 years. And the nice thing about it, that it also gives you a text summary, and it also checks the assumptions of the study before it gives you the results. So it's really good. Obviously, it's not going to be as comprehensive as R or Stata as we see, but I think for the price, I think it's a really, you will be up and out like that with the DataTab, because it does the assumptions for you as well. GraphPad is used to be the most friendliest software around. It was developed by a biochemist from University of San Diego. It has become more and more expensive. It is not a comprehensive one, but the feature set for the basic statistics are fantastic. And also you can produce beautiful diagrams, but it is expensive. And then there's something called Wizard Pro. It's only Mac. If you are going to do logistic regressions, then I think Wizard Pro is well worth the investment. It's a yearly subscription about £39. SPSS used to be the stable of statistics, but IBM has bought it or rebought it. Now it's extremely expensive, about £2,000. If your university offers it, it's a good software. I started in Excel Stat. It's around £500. It's a module that goes into Excel. This is the one Dr. Dasling Pang uses it. He's the one who recommended it. Once you buy it, you can use that forever. But if you want every year update it, then you can pay the money. To be honest, for our statistics, once you buy it, that's good enough. But once again, it's pretty comprehensive and easy to use, and good tutorials, and the staff are very good. Then there's something called Stats Direct. This was developed by a professor of mathematics from Manchester. He developed it specifically, so it's comprehensive, but it's also not expensive. So it also gives a special discount for people from developing countries. It has a 3-year license. Once again, I think it's about £99 if it is British. If you are from developing countries, then there's a discount as well. But it only works on Windows. Then Stata is very, very powerful. The nice thing about Stata is that if you buy it, then you don't have to, you can buy it and don't have to pay a subscription. And SAS is pretty much the king of the softwares for statistics. That's used by all these big surveys, and they use millions of data. But it's very expensive, and also the learning curve is steep. You have to write code. So I have never even got near SAS. So my recommendation, if you are a beginner, no one has given me anything, so it's absolutely unbiased, is DataTab, German company. That the software is in different languages as well. And GraphPad, Prism. If you have both of them, you are quite sweet, I would say. But if between the choice, I'll go for DataTab. If you have money to spare, then I would say you can get both of them. And if you have a Mac, I would say it's really worth. And if you are really interested in doing studies, looking at multiple factors, Wizard Pro is absolutely beautiful. It not only you can do logistic regression, but you can create models. So like let's say that if you want to create a ETVSS score, it does it for you, and then you can even upload it so that people can actually do the calculation on the web and figure out the risk of poor outcome or good outcome. If you are a Windows person and you want a comprehensive one, Stats Direct is great. And if you are starting out in neurosurgery, and you are a very ambitious person and want to make a massive difference to neurosurgery with research, I think if you get Stata, it's about £500 with academic license. Then you are pretty much in 10 years time you'll be humming. So thank you very much. I hope you found this useful. If you have any questions, please put it on the chat box. I think my talk probably has been taking longer than I should have, but please put any questions on the chat box. And if any further questions in future, please feel free to email me. Thank you. So Let me see if there's any questions there. Okay. So the next one is next talk is from Dr. Elias Riz. Dr. Riz, do you want to share your presentation? Dr. Elias Riz is neurosurgeon from Penn State University. He is one of the proteges of Dr. Harbaugh. He's a pediatric neurosurgeon as well as peripheral nerve neurosurgeon. He's prodigious, absolutely prodigious. And it's a real honor to have know him as my friend. I collaborate with him on many projects, and it's a real honor to have Dr. Elias talking us about this important and one of the commonest statistics, comparing means. Thank you, Dr. Elias Riz. Thank you.
Thank you so much for this wonderful introduction. And I'm riding on shoulders of giants like yourself and Dr. Harbaugh, allowing me to talk about this topic. And there's going to be some formulas dispersed in the slides here, but it's not geared to make you remember the slide formulas. What I'm trying to achieve here is to simplify the way you address comparing means and try to figure out what's the best way to address a data set and what the appropriate questions you need to ask when you're analyzing the data. So we often compare two individuals or units from individuals from two groups, and you can come up with different examples of different scenarios that you want to compare to, including, for example, customers in a supermarket. Do females or males spend more of the same or more? Or bank accounts, if the ones that have more transaction accounts are any different than the ones that have lower transaction accounts per charges, and by how much? Or even, if you're using two different machines that are filling volume of a tank with milk, any differences in what those two machines are providing. And we want to ask more about the specific customers who entered a certain scenario, like a supermarket, or the specific bank account that were sampled, and not about, you want to generalize the assumption, not ask one specific difference between these two observations. We are therefore usually interested in the characteristics of the population or the process that we assume that underlines the data that are collected. And the data usually provides information about what likely characteristics of this population you want to review. The way to understand the data first is to, number one, categorize this data and say, this is a numerical data, this is a continuous type of data, this is a categorical data, but more also to be relevant to your analysis, you really should plot the data and determine if the plot distribution is a normal distribution, and that will dichotomize the way you address or try to understand what's the best way to analyze the data. And this is an example of two groups, and once you have that data, you can plot it and figure out if it has a bell shape or a Gaussian or a normal type of distribution. And if the data is noticeably skewed, and there's formulas to calculate the skewness of the data or the normality of the data, then you can choose to utilize the appropriate statistics to answer the questions. And the other important topic to glance over here is to determine where in your rejection area of that curve you're looking at as a positive or negative tail to reject your hypothesis. And you can place your rejection hypothesis either at the both ends of the tail of the Gaussian curve or the normal curve, or you can choose as a one-tailed t-test where the majority is at one end of the curve that you're trying to see if it's an area of rejection or not. So again, the top example is a one-tailed t-test, or compare that to a two-tailed t-test. And when you're doing this, instead of having whatever cutoff you're looking at, be it 0.05 or 0.01, then this whole area under the curve should equal to that amount. The t-distribution also changes its shape with the number of observation that you're looking at. And obviously with lower numbers, the skewness of the curve gets fatter and the edges get thicker. And the more numbers you have, it becomes more narrow at the top. So this is a good example of a student t-test distribution, and with uncertainty and lower number of observations, the curve becomes fatter, and at the ends of the distribution becomes bigger. So going back to the differences between means and how to compare means, for two data sets, we usually want to compare what's underlying in the population. And a particular question that you want to raise, are the two distributions the same? And if they are different, then by how much, and is it a significant difference that you're looking at? In comparing the populations, it's important to, first off, just like Naren went over in the sampling of the data, is to figure out the natural display of the data and figure out the mean, mode, whatever type of average for the data, and also the standard deviation of the data. And then you can have a clear visualization of what you're looking at in your analysis. And then you take it to the next step. And once you have examined the side-by-side plots, you can turn to the comparison and try to figure out if the parameter of interest is different between the first or the second population. The t-test may be used to evaluate whether a single group differs from a known value, or even a t-test from a paired comparison between two groups that are either matched or unmatched. And one sample t-test is used primarily when you have a small sample population, less than 25 in your cohort, and you don't know what the standard deviation for the general population is. And this one sample t-test is a statistical hypothesis test used to determine whether an unknown population is different from a specific value. And these are the formulas here. And this is just an overview of what the quick reference t-test should test. And then this is your formula for your test statistics. And the degrees of freedom is typically the number of values you're looking at -1. And this is your p-value that you checked ahead of time, and your threshold. And then if it's less than 0.05, you can reject the null hypothesis. And if it's more, you can fail to reject the null hypothesis. So again, an overview or reference, why would you use the one sample t-test? It's mostly to compare the means of a numerical value to a hypothesized value. The individuals are randomly sampled from a population that is normally distributed by assumption. And this is the formula at the bottom that you utilize to compare this group of individuals. Now, in a paired t-test, this is the formula that you're looking at. And in this instance, you're not looking at the total number of observations, but typically the number of pairs in the cohort that you're looking at. And you can have two types of pairs in this sample. So you have a paired t-test where you have one observation, and then you do an intervention, and then you follow up on that observation, or you have two random samples and you want to compare the two means or averages between these two populations. So again, the data from the two groups in a paired sample can be paired, and there's one-to-one correspondence between the individual and the two groups. And to give a couple of examples of this, you can see that, for example, identical twins raised in different environments, this is more on pairs, or before and after treatment, for example, having tattoos, and is it the best way, which one was the best way to remove the tattoo, be it lasers or dermabrasion, or same river upstream or downstream, is there any difference in the analysis of the water at that level? To compare two groups in a paired comparison, we use the mean of difference between the two groups. And the data injuries, for example, this is a good example of data injuries in a company that had instituted an observation of injuries on no smoking days versus smoking days. And this is the data per year. And then you see the number of injuries per day based on smoking days versus no smoking days. And to calculate the difference, you take the differences between these two observations, and then you want to compare the means of the differences to a value of a given null hypothesis. And the main question here, is there a difference between smoking versus no smoking for work-related injuries? And then the number of observations here is not going to be the total number of numbers in these two columns, but more so the number of pairs that is important as far as calculating the degrees of freedom between the two cohorts. And when you use the t-statistics, you can calculate the number and you can see if you can reject or not reject the null hypothesis. So the assumptions from a pair t-test, pairs are chosen at random and the differences have a normal distribution. So the outcomes of the with or without smoking, the groups that you're looking at, once you plot them, should have a normal distribution. Again, a quick reference for a pair t-test. Usually it measures the mean difference in a population equals a null hypothesis value. The pairs are randomly sampled and should have a normal distribution. And the degrees of freedom that you should be looking at is not the total number of observations, but the number of pairs in these two groups. So the two sample that are not paired is when you are comparing the parameters from both populations, and the research hypothesis is one intervention different from the other, and the null hypothesis will be rejected if it's the same outcome between the two cohorts. You have to have several assumptions when you're looking at this type of analysis. And the randomization condition is where the data collected with suitable randomization. And the 10% condition, when we don't usually check these conditions for differences of means, we will check it for means only if we have a very small population or an extremely large sample. So the variances of both populations should be assumed to be equal. The normal population assumption also is when the two groups must be checked for violation of this, because if it's not normal, then you have to transition to the non-parametric analysis of these two groups. And the two groups should be assumed to be independent when you're comparing those observations. So this is the summary statistics slide of two sample t-tests that are not paired. And this is the test statistics for the t-test. And the number of the degrees of freedom is going to be the total number of the observations in the groups minus 2 to calculate your degrees of freedom. So again, a summary slide of the two sample t-test that is not paired. Test, and this is to test the groups that have a certain mean, and this is where you're trying to compare these two observations. Your assumption is that both samples are random samples and they have a normal distribution, and the variance of the distribution is the same in the two populations. And to be able to calculate the degrees of freedom, you're going to have to calculate the total number of observation and remove 2 in this instance to get your degrees of freedom. Now, when you're comparing means when variances are not equal, then you can use the Welch t-test, which compares the means of two cohorts that are normally distributed, but the variances are not equal in these two cohorts. If you have multiple observations or multiple groups, then you have to do an ANOVA or analysis of variance. And in order to conduct an ANOVA, you also have to assume certain important factors at the get-go of the analysis. And this is where you have to assume that the population from which the samples are drawn are normally distributed, and the population from which the samples are drawn have equal variances. And the test statistics for this one is an F statistics. And the numbers of distribution for the F statistics will be the degrees of freedom, which will be the total number of the patient population minus K. So this is, again, a visualization of what you're looking at. And mean square is what you're looking between the group between to get the F statistic and divided by the mean square of the error. And you're comparing it to the null distribution and see if that rejects or fails to reject the null hypothesis. So this is just a visualization of the ANOVA, and the variances of the groups are partitioned into two in between group variances and within group variances. And then you're calculating the mean squares of these variances between the two cohorts to be able to obtain your F statistics. Now, remember, in the T statistics, it was more of a normal distribution, but the F statistics has a different shape to the curve, and your rejection area will be a different shape to the curve compared to the T statistics. So just to clarify the ANOVA with an example, so you're looking at rates of depression after a treatment, being, for example, medication, counseling, or diet. And you calculate the mean square for each of these cohorts. And then you calculate the F statistics based on the mean squares of the observed minus expected versus the mean squared within. And you have to calculate the sum of squares that are usually formulas that are provided automatically by the software that you're using. And then the degrees of freedoms for the number of groups versus the numbers within versus total, each are variable in this instance. So, for example, the treatment groups, the sum of squares of treatment versus the intervention versus total, the degrees of freedom is K minus 1 versus N minus K versus N minus 1. The mean squares will be for the group is the group versus the degrees of freedom versus the error is between the sum of squares over the degrees of freedom of the squares, and then you can calculate the F ratio. All this stuff is performed automatically for you in the statistics software, but it's important to note what happens behind the scenes when you're trying to calculate this data and then trying to figure out the p-value for these interventions. So this is, for example, just an example of an ANOVA table and the data that spits out at the end with the F ratio and the p-value that you're looking at. For factorial ANOVAs is when you're containing multiple independent variables and you're comparing different outcomes in independent variables. And the main effect is to indicate significant differences within a single independent variable. And also interactions indicate significant differences across two independent variables. So you can see a two-factor ANOVA will be able to see a difference between the treatment group or between treatment 1 and 2 combined. And finally, for non-parametric tests, these are usually selected for distributions where the patient or the population you're looking at, the sample size is small, or the distribution is not normally distributed, or the data that you've already plotted are badly skewed. And the transition from parametric or normally distributed versus non-parametric distribution is for the one sample t-test, you'll use the sign test, but more so when you're comparing two samples and two means, heavyweight lifter, the name that you have to remember is the Mann-Whitney test. And then the Mann-Whitney test, you're comparing two non-normally distributed populations to figure out if there is a difference between these two samples. And this is the formula that you'll be using for the Mann-Whitney test. And this is where you have samples that are not distributed appropriately through a normal curve. And this is an example of what you'll be looking at. So for example, you have data with different observations. And when you sort the data, you see that the data have a skewness to it and maybe more heavily skewed to the right side. And you have multiple observations with the same number of observations, so that you have multiple ties in the data sorted. But you rank them anyways, and you give them a rank between 1 to 8. But in order to find the average of the ranks and the prior assumptions of these two observations being equal, then you provide these, for example, an average of 1.5 and the observation 5, 6, and 7, a rank of 6. And when you rank them, you can determine that these are non-parametric distribution of the data, and you have to use a Mann-Whitney test. The benefits and costs of non-parametric tests, the main benefits makes fewer assumption of your data, and the main costs that you're putting into this is that you're going to lessen the statistical power or increase the chance of type 2 error in your data. And when you have reason to suspect the assumptions of your test are violated, it's mostly because it's a non-normal distribution and there's differences of variances between these two groups. So again, summary of the data of non-parametric tests. You use a sign test. It's usually used for comparing medians of groups to some extent. The sample is assumed to be random, but the distribution of the data is non-normal. And this is the summary slide statistic of what you're using for the sign test. And then the Mann-Whitney test, where you're comparing non-parametric means of two samples. The samples are random, but the distribution is not normal. And that was my overview of means. Happy to answer any questions.
Thank you very much, Dr. Riz, for that comprehensive overview of the statistics for assessing means of two groups. Once again, any questions to Dr. Riz? Please put it on the chat box. Dr. Riz, you went through rightly so of the understanding the background to how you, when you press the button, what happens, and how much you need to know to use the software, and what's your thoughts on that? Because it's not easy understanding to get a grip of all the maths and then to remember it. And how, if you are interested, how you go about studying it, and what software you use for your statistical analysis, and when the results comes out, how do you then check things through?
So the first thing I try to use is try to define the data that I have and try to figure out what type of data I'm working with. Is it categorical data? Is it ordinal data? Is it numerical data? And based on that information, I start to understand the next best statistics to be used. The second step in that comparison is to figure out what type of comparison that you're doing. Is it two separate populations and you're comparing their means, or are they related in any way in a paired fashion? And once you figure this out, or if you have multiple observations, then you can change the type of statistics that you're going to use. Before going to that next step, I would like to graph the data and see how it's normally distributed or not, or put it through, there are softwares that you can determine if the data is normal distributed or not. And that tells me, am I going the parametric or the non-parametric type of analysis of my data? And once you have all these basic checklists figured out, then it becomes an easy task to say, oh, I want to do an ANOVA, or I want to do a paired t-test or a non-paired t-test or a Mann-Whitney test based on the data that I have.
And in terms of software, what software do you use for your statistical analysis?
So I have used all this softwares that you mentioned. I like GraphPad, and as a student, you can get a significant discount for GraphPad. I like GraphPad mostly for the graphics that you talked about. So it provides beautiful pictures and nice overlay of the data that you have. But for more in-depth analysis, I do a couple of software between SPSS or SAS, or even the MATLAB software that you have. I have not used R. A lot of people mention that R is very user-friendly, but I have not used that myself.
Thanks, thank you. Just a small tip is that, if you have a university account, in Britain, many of the consultants are honorary lecturers with the university and they get a university email, then you might be able to have access to the university software. So you don't necessarily have to buy it. I used to have a honorary contract with University of Southampton, and it was like Aladdin's cave, their software library. Every software I can get a hand on it. And the other thing is, if you do buy software, then you can always say that you have got a ac.uk account or academic account, and you get a very good discount as well. So always worth looking at that. Thank you very much, Dr. Riz, for that excellent talk and your insights into this very common statistical test that we usually do, comparing means. And are you happy, as you said at the end of your lecture, that you're happy to take any email questions if they come later on? Would that be
absolutely?
Oh, brilliant, thank you.
And there are lots of forums online to ask questions and say, I have these two cohorts. What's the best way to do this? Or can you help me do the software coding for averaging these two means? So there's lots of good resources online, quick access to figure out what's the best coding to do in your SAS type of data analysis.
Brilliant. Thank you very much. Before we go to Dr. Nichalas Brandmeir, just to let you know that on the feedback form, I will be having one question regarding workshops. In the days when we had the International Neurosurgery Residency course from 2016 to 19, or certainly in the ones from 2018 and 2019, we had a statistical component to that course. We have, for 2 days, the delegates would have lectures, and then they will work on problems, doing every statistical test and planning studies and then undertaking studies. So if you would be interested in attending a weekend statistical course, I have got good friends in Croatia. Dr. Jurasin is here. I will try to talk him to it. Or in south of Italy, or even in UK, please, on the feedback form, please mention whether you are interested and which country you would be interested in attending. So it gives me a great pleasure and privilege to introduce Dr. Nichalas Brandmeir. He is also a protege of Dr. Harbaugh from Penn State University, where he did his residency. He's now a consultant neurosurgeon, or attending neurosurgeon at the University of West Virginia. He's a colleague of Dr. Cara Sedney. Dr. Nichalas Brandmeir was one of the faculty at the Amsterdam course, where we had this 2-day workshop. So Dr. Nichalas Brandmeir is going to talk to us about how to compare groups when they are qualitative variables than quantitative variables. Thank you, Dr. Brandmeir.
Thank you, Naren. So I'm going to talk about how to compare. Want to make sure I'm not echoing. I had to throw my phone far away from me. I'm going to talk about how to compare categorical variables. So let me share my screen. Oh. I just need permission to share, and then we'll be.
You should be able to. You should be able to share.
Oh, try. I might be under as a different name.
Oh, which?
Because I'm on my.
Which name are you on?
Computer and my phone.
Okay, okay, I get it. Okay, sorry, beg your pardon. Great.
There we go. Okay, perfect. Thank you. Okay. So thank you for the nice introduction. Here's my data demographic stuff. I'm a partner of Dr. Sedney, who we heard talk earlier. I'm going to talk about contingency tables, which is really how we compare categorical variables. So we're going to talk about basically everything from the beginning to how to actually do the test, and then we'll have like a fun example at the very end that I think is important and illustrative of kind of the bigger picture of what we're going over today with the course. So I always start any statistics talk that I give to my own residents or anybody is with the 3 threats to validity. So it's important to remember that the 3 threats to validity when we look at studies are bias, confounding, and chance. And the vast majority of this course, other than what Dr. Sedney talked about, focuses only on chance. So there's no statistical way to account for confounding, and there's no statistical way at all to account for bias. And so we're only really focusing on the 3rd out of 3 tests or threats to validity. So first we need to think about how are we framing a statistical question or a clinical question, because that's why we use contingency tables. That's why we use categorical variables so often, is because it's clinically relevant. So you have a patient or population, you have your subjects, you have your intervention, for instance, coiling versus your comparison, clipping. You have the outcome, patient mortality, re-rupture risk, what have you. And then you have time at 1 year. So for instance, it would be people with ruptured aneurysm getting coiling compared to people getting clipping, and the rebleed risk at 5 years. And that would be a clinical question. So what you can appreciate as you formulate a standard clinical question is that it sorts itself into categorical variables, because coiling and clipping are not related to each other mathematically. And rebleeding, yes or no, there's no mathematical relationship between a rebleed and a no rebleed. So those are 2 categorical variables. So if your outcomes and your interventions are categorical, then you have to use contingency tables, or I would argue you should use contingency tables to keep track of the data. And then this is how we're going to examine those things. So just a reminder, mathematics is a tool. So if you inappropriately apply mathematics, it's no more effective than inappropriately applying a hammer. So if you see studies that use statistics to come up with false or aberrant outcomes, you don't condemn all statistics in the same way that you don't condemn hammers just because every once in a while somebody hits their own finger instead of the nail. And in the same way that if somebody uses a hammer, to build an ugly fence next to you, that doesn't mean that hammers are only useful for bad things, right? It doesn't guarantee you that even a correctly used tool can't produce a negative result. So sometimes you'll see studies using statistics correctly, but because of design flaws and biases that aren't accounted for statistics, lead to an odd result. So let's start with a clinical question. So we'll talk about, does a decompressive hemicraniectomy help with patients with stroke? So first we need to look at patients with ischemic stroke and malignant edema. Then we need to do a decompressive craniectomy and compare it to medical therapy. And then living at home with minimal help, so modified Rankin scale or utility adjusted modified Rankin scale or something similar, at 2 years, because they need plenty of time. Old, they have pneumonia after their hospital stay, whatever. 2 years is the appropriate stay. So then once we've got our clinical question, it's going to make data gathering very straightforward. So then you can build up a contingency table. And this is going to tell you exactly how to run your experiment. So we want living at home for 2 years, treatment A, treatment B, yes and no. And then we just count. Then we just wait over a certain number of patients and we count. You'll notice that it doesn't matter whether it's a randomized controlled trial and you're getting randomly assigned to one or the other. It doesn't matter if it's a retrospective study. It doesn't matter whether it's blinded or not blinded. So you can see when you look at the outcome table that all of those issues with level of evidence and blinding and study design don't have any bearing on the actual statistics at the end. So once we've got these counts, we need to know, well, you can just like add and subtract, but how do you actually know how big the difference is? How do you turn this numbers into the things that Naren was talking about earlier, relative risk or odds ratio? So the first thing you do is you're going to add some columns. And so far, I'm going to kind of keep up with the math as we go through. Computers will do all this for you, but so far the only mathematics we've had to do for this is counting and adding. And so we're just going to add the rows, we're going to add the tables, and we're going to come up with our N, which is the total number of subjects in our study. And then we just label these cells, you just label them with letters. So cell A, B, C, and D, and then you just can compute change the math that we did before into kind of these simple algebraic notations. And so then I'm going to kind of keep this relationship in mind, but we're going to go through. So the relative risk, as Naren said, for data is A divided by A plus B, or C divided by C plus D. So the risk is the likelihood of A out of all the people getting that. So if we look at back here, so the risk of craniectomy would be A divided by A plus B. So the percentage of this number that this number takes up is say the risk, the relative risk. And so then when you get an absolute risk reduction, you're going to just subtract those things. So it'd be A over A plus B minus C over C plus D. That's your absolute risk reduction or your risk difference. Your relative risk is going to be this. You're going to take these same risks that you take from each row, but you're just going to divide them by each other. How are they related? That's how you're going to get that 0.5, 0.2, 0.01. The number needed to treat, as Naren said, is just the inverse of the absolute risk reduction. So you're going to subtract, and then you'll subtract the risk of surgery or whatever minus the risk of your other treatment, and then divide 1 by that number, and you'll get the absolute risk reduction. Odds ratio, which will work for all data, but usually we save it for retrospective data because of its difficulty in interpreting it, is A divided by B and C divided by D. So if you can compare, risk is A divided by A plus B, odds is A divided by B. And that's because with an odds ratio, remember, odds are more correctly written with a colon, A to B. So 1 to 2 here would be 1 divided by 2, or 1/2. If you look at risk, right, if A is 1 and B is 2, then it'd be 1 divided by 1 plus 2, or 1/3. So then your odds would be 1 over 2, and your risk would be 1 over 3. So it's just important to know that when the numbers are small, like if B were 10,000, say, and A was 1, then it's 1 over 10,000 versus 1 over 10,000 plus 1, which is the same number for medical data, right? So that's why it's important to keep those in mind. With big numbers, odds and relative and risk basically are the same because of this relationship. With small numbers, they are very different, like we just looked at. And then, of course, the odds ratio is you just divide the odds from each row. So if we look at our data, I just computed it for us. So we've got a relative risk of 1.6 and an odds ratio of 3.5. And then the answer, how are we done? Well, now we know the odds of doing well at 2 years is better with a craniectomy. So we should just do craniectomies. But there's something missing, and that is, what's the risk of a type 1 error? What's the risk that the difference that we've seen isn't real? And so we need to figure that out. And so because we're talking about type 1 errors, we're talking about p-values, which is going to tell us the probability that this is a type 1 error, or that this result could be a type 1 error. So remember our accuracy, precision, and bias. So here's we're neither accurate or precise in A. In B, we're precise but not accurate. In C, we're accurate but not precise. And in D, we're both accurate and precise. Now, bias, you can see here we're accurate, we're not accurate and we're not precise. Now, this is bias. So condition B is a statistically well-designed study with a fundamental flaw in its design. Because this difference away from the true mean, that's what bias is when we talk about bias. So, so when we talk about the tests, so we know how to assess for like the clinical difference or the actual difference between the values, but now we need to look at how do we test for precision? How do we test for type 1 error? And so what we're going to do is we're going to compute the expected values for a cell. What do we expect the cells to have if it's just random? and then see where the differences fall on a specific distribution, the chi-squared distribution. And if we are, and then where we fall on that chi-squared distribution is going to tell us what our p-value is going to be. Now, the reason, like I said before, the reason that we're doing this in the first place is we don't have normally distributed data. If we had normally distributed data, then we would use one of the things that Dr. Riz just talked about. The difference here is that our samples of the population have a distribution. So anytime you sample a population, the act of sampling itself will have a distribution. The chi-square test makes the assumption that your sampling distribution follows a certain pattern related to large numbers. And if your sampling doesn't follow that pattern, then the assumptions of the chi-square test aren't going to work. We'll take a look at that. So here's our data, same exact data. So here's the proportions living at home here, and here's the proportions of the patients living with a decompressive craniectomy. So that's how we know which out of this 89, how many had a craniectomy and how many are living at home. So then once we get that, we can find the expected value of A, because we just multiply those by this formula, and that's going to give us the expected value of A. And then we know the expected value of A. So here, if we follow that formula all the way through, then we get the expected value in every single cell. And then if you add them all up there, they come to 89. So this is the expected value. So now we want to measure how far our number in each cell from our study varies from this expected value. Then we're going to calculate these. And so what we're going to do is we're going to get this observed minus expected squared divided by expected for each cell, and then add them all together. And then that gives us our chi-squared value. So it's 35 minus this squared divided by the expected value. And then that's going to give us these numbers. And we're going to add those up. So again, this is the most complex math we've done. And all we've had to do so far is square. So mathematically, this is very simple. It's just understanding so you could do it with a pen and paper if you had to, which is another reason why it's so popular, because for the majority of time that these studies have been done, they were done with a pen and paper. So then you get your chi-squared number, 7.49. And then this is a little bit of a blast from the past. You have to find a textbook with the chi-square distribution, and you're going to look for degrees of freedom. For a 2x2 table, you have 1 degree of freedom. Okay. And so we're going to find this black line, and then we're going to find our chi-squared, and ours is 7.32, I think. So we're going to find where 7.32 intersects the line, find the y-intercept, and then that's our p-value. So our p-value will be here's 0.01, 0.05, so 0.001, or somewhere in there. Now, of course, all this is done by computer, but you can see that if you had to, you could very easily do the chi-squared in Excel, or even, like I said, with a piece of paper. Now, the reason the degrees of freedom are, we might be saying, well, wait, how come the degrees of freedom are only 1 when we've got four boxes, right? We've got 4 boxes here. So how come we only have 1 degree of freedom instead of 3? And the reason is, once you make one choice, all the other cells are mandatory, because these numbers don't change on the outside of the rows. So these numbers out here on the edge never change once we've set up our box, because that's how we get our expected values. So once we set 35, well, then 57 minus 35 is 22. And then 44 minus 22 is 22. And then 32 minus 22 is 10. So you can see that once you put one value in a box, that's the only choice you're allowed to make. And degrees of freedom are how many choices you can make for your data. So that's why there's only 1 degree of freedom instead of 3. So the problem with the chi-squared, as I hinted at, was because it's based on parameters from sampling, so the expected values don't reflect the reality if the sample's small, because you have the problem with small samples. It's just a sampling error issue. And generally, a rule of thumb is if you have under 10 if you have less than 10 per cell, or if you have a cell with under 10, then you shouldn't use a chi-square. Using the chi-square is gonna give you potentially a false p-value. So the solution is the exact test, Fisher's exact test. And the bonus of Fisher's exact test is it's an exact test. So unlike all the things that Dr. Rizik just talked about, and the vast majority of the things we're going to look at, the Fisher's exact test requires no assumptions in the data whatsoever. It always will work. So in the Fisher's exact test, if we know the values in red, as we just went over, then you only need the value for one cell. That's why there's only 1 degree of freedom. We just went over that. So it's this concept. And then, so if A is constrained by A plus C, and A plus B, and A plus B plus C plus D, in a similar way to picking a 4 of clubs is constrained by what you see there, the rate of clubs and the rate of 5s and the number of cards. So once he knew that, you can do the, you can find the odds in the same way that you'd find the odds with like a gambling question. And so if we look at the, just to go over the binomial expansion and the math. So what this is saying is n choose k. There are n ways to take unordered groups of size k from the total group of n. And the way to get, so how many ways, so n choose k, like how many ways are there to n choose k, is this formula here, n factorial divided by k factorial times n minus k factorial. So 4 things taken 2 at a time, you put 4 taken 2 at a time, 4 factorial divided by 2 factorial times 4 minus 2 factorial, and then you expand it out, and then you can do the math. And then you get 6, and then sure enough, if here are all 6 of the groups. So what's the probability of getting one of like the group 1, 3? It's 1 out of 6. So this is a very simple example of like binomial expansion, but you can use the exact probabilities of any given arrangement or 2 by 2 table with fixed margins. If you have to know the margins, but once you have fixed margins, then you know the exact probabilities of the arrangement, expected values in the table. And this is all tables from medical literature will follow this pattern. So then we can kind of expand it here. But here is why, well, then you might be saying, well, why don't we, so here's the binomial expansion of the Fisher's exact test for a 2 by 2 table. And if we have that, why don't we just use the Fisher's exact test all the time for everything? And the reason is that you can see if A is like 100, C is 250, B is, I don't know, 75, and D is 942. Like, think about doing those factorials out here, because you'd have to multiply all of those out, expand all of those out. It quickly becomes impossible if you're not a computer. And so for large numbers, because these used to be done by hand, the chi-square test is more common. With modern computing power, it's almost inconceivable that you can come up with a 2 by 2 table that the computer couldn't easily just crank out a Fisher's exact test in just under a second. So by and large, the Fisher's exact test is always right. It's never wrong to use the Fisher's exact test. Chi-square test can be wrong if your numbers are small, either, and usually the rule of thumb is less than 10 in a cell. But again, if it's 11, 12, 13, 12, well, none of them are under 10, but they're still pretty small numbers. I would feel nervous about using a chi-square test in that case because it's just a rule of thumb. So once you find the P for every table, you add all the P's together. So for every table, you've got your observed results or rarer, add all the P's together, and then you get the P value. So this is exact because it gives you an exact probability. It doesn't rely on estimates. We talked about that. Confidence intervals. These are also found using a binomial expansion for a ratio. So the confidence intervals, and this is like, you just use the software. This is what Naren was talking about. We got a little bit into kind of to stretch Naren's car analogy. We got a little bit into it, right? Like we can maybe replace the antifreeze. We can change the oil, maybe change a tire, but this is getting a little bit more complicated. And so for these confidence intervals, you're going to use your statistical package to calculate that. And then it usually will come whenever you do, say, you give it a contingency table and a chi-square test. So this is just a little fun exercise. So here's a contingency table for the literature. I didn't do the math, but they're all 1,000. So it's 1,000 or it's 1,000 going this way. So you got condition A and condition B, outcome yes, outcome no. And this is an actual study from the actual literature that I looked up before the course. And you don't have to respond to the chat or anything, but everybody look at that. Here's a p-value and just decide for yourself whether or not you think that condition A is superior to condition B. It's not a trick question or anything. So everybody's looking at this, and it seems like, and again, it's statistically significant that condition A more often leads to outcome yes than condition B does, because this p-value shows that this difference is very unlikely to be random. So there's got to be something going on between condition A and B that's driving this outcome. But here's what the actual thing they were studying in this paper was. So condition A was a pornographic picture, and condition B was a neutral picture, and the subjects were trying to psychically detect where the picture was behind blinded screens. And so the conclusion of this paper was that college students can psychically detect pornographic pictures at a much higher rate than they can detect neutral pictures. And so the statistics were used appropriately. They used a contingency table. There's no problem at all in the study with the statistics. The problem is like all the other things that aren't statistics that we talk about with study design. Things like doing multiple studies on the same subject over and over again. Having very low kind of unspecific outcome measures and things like that. So again, don't get bogged down on the statistics to the point where you start seeing crazy things like a study that shows people can psychically detect pictures, which obviously isn't the case. So with that, I will take any questions in the chat and take a look now. And I'm also available by email and for questions after the course. Thank you very much.
Thank you very much, Dr. Brandmeir. That's a overview of comparing groups. It is probably as common as the t-test, and many of the randomized control studies, if anything, use this statistics, which is, as Dr. Brandmeir said, it's pretty straightforward in most of in most of the circumstances, knowing which statistics is selecting chi-squared, Fisher exact test, and is the question. And once again, this is a basics course, but then if you are going to compare more than one groups, also becomes more complex, but not, and you have to get software for it. Thanks, Dr. Brandmeir, for taking any questions if they are sent on the chat box or through the email. I think once again, all the lectures will be available on the YouTube. My presentations will be available as PowerPoint presentation as well, or so on the web, so you can go through. Sometimes easier to look at a PowerPoint presentation than a video sometimes. And Dr. Brandmeir, would you be willing to have your PowerPoint presentation put as a presentation on the web as well?
Yeah, no problem. I'll email it to you.
Thank you very much. So I think it brings the program now moves to my talk on correlation and regression. So let me just get the PowerPoint. Can you see the presentation now? Dr. Brandmeir, can you see my presentation?
Yes.
Oh, brilliant. Excellent. Look, so I'm going to take you through correlation and regression. it's one of those statistics which is not, which looks like it's not complex, and it is not complex. Actually, most of them are not that complex. We have neurosurgeons. If you ask a statistician about neurosurgery, he will say that's complex. So first of all, when you approach these things, just remember you are neurosurgeons. These are not that difficult. So I'm first of all going to take you through what correlation and regression is, then correlation and regression. There are a lot of slides, but they are easy slides to look at. And so let's start. So correlation leads to regression. It's like, I said to myself, I will not use the analogy, but it's like love and marriage. You start with correlation, and if things are correlated, then you go to regression. Correlation is about looking at the association between one factor or two factors or three factors, how they are associated to each other. So if you say, does the height, if you go to a class, does the height of a student correlate with the weight of the student? So most of the time, the taller the kids, they are going to be mostly heavier, but not all of them. But this is where you are looking at correlation. Correlation is to looking at association. Regression is to look at two things. One is to see how one factor influences the other factor. Can you please mute your microphone? Thanks. So regression is two things. It's like, how can everyone mute the microphones, please? Thank you. Just a second. Okay. So regression tries to answer two things: how one factor influences the other factor, and to predict. So one analogy, basically, it helps you to predict things. So for example, the endoscopic success score, ETVS, endoscopic ventriculostomy success score, is derived from a regression model. So the commonest thing is to say, if someone has one child first year, second child second year, so would the person have 10 children by 10 years time? So this is, you are trying to predict. Obviously, at certain points it can be linear, but at certain points it might, the relationship can change. So that's where the regression is. So as I said, correlation is about association. Regression is to look at the influence and try to be able to predict things. So, correlation used to be not so sexy subject before, but nowadays, pretty much most of AI is based on big data, and the AI tries to correlate things with the look at the association between, what middle class people buy on a Sunday, or if I use a word correlation, what's likely to be my next word. That's what the ChatGPT does. So correlation has now become an unbelievably powerful tool. And for regression, you have to have a model. So regression looks at the pattern, how one variable is related to other, whether there's a pattern, because we are trying to predict further data from a different X. So in terms of the models, when we say models, there has to be it looks at a mathematical relationship between two data. So here, the one here you see is a linear model. Here you see a U-shaped data, which will fit more a quadratic model, X raised by 2. Or here you see a sinusoidal data pattern, which will probably better fit with a sine function. And in terms of regression, regression is a huge field. There are several forms of regression. You have got the linear simple regression, which I'm going to talk to, because if you understand simple linear regression, you can understand the other regressions. Multiple linear regressions also assume that the relationship is straight, but rather than looking at one variable with the outcome variable, one dependent variable with a one independent variable with a dependent variable, it looks at multiple dependent variables, multiple independent variables to the outcome. So let's say here, if you look at the usual previous example, if you look at, is the height going to be influence the weight? But here you can look at the height of the person, and in the multiple linear regression, the girth of their chest, the girth of their hips. So here you are using more than one factor. So, and if you think that the model is still linear, you will use multiple linear regression. If the relationship is not linear and you think it's more in a curve, then you will use a non-linear regression. And logistic regression is a special regression which is commonly used when the outcome is qualitative. Like, the patient had, if you look at chronic subdural, did the patient have recurrence or not? So whenever it's a qualitative outcome, then you use logistic regression. As I said, we'll concentrate on linear regression for the moment. So now I will start on correlation. As I said, with correlation, usually that you will use continuous variables. You can use ordinal variables, but if you use ordinal variables, then you are better to use this Kendall tau. But if you are using continuous variables, it's Pearson correlation or Spearman correlation based on whether they follow the data follows normal distribution or not. And if it is, so here certainly continuous variable, you can use correlation. If it is continuous versus a nominal, so if you say height versus gender, if there are just two variables, then you can use a correlation called point biserial correlation. But if it is just between groups, then obviously you have to go to what Dr. Brandmeir was talking to about a chi-square Fisher test, but not the correlation that I'm talking about. So then most important aspect of correlation is to know whether the distribution is normal distribution, that's parametric, or whether it's non-normal distribution, that's non-parametric. Because if the distribution is parametric, follows a normal distribution, then you can use Pearson's correlation. And if it is a non-parametric data, then you will have to use Spearman rank correlation. So how do you know whether the data is normal, has a normal distribution or not? There are a number of ways you can test it. The first way is to use statistical tests. So there's the Kolmogorov-Smirnov test, and a variation of that one, the Shapiro-Wilks test, Anderson-Darling's test, and one of the regarded tests is D'Agostino and Pearson test. So most of the softwares do give you these tests that you can check the data on. At the very end of this presentation, I will quickly give you a demonstration of it. And so this is from the DataTab, this one. And whenever you are going to test something, you have to know what's your null hypothesis, what's your alternative hypothesis, and what are you going to set as the significance level. So null hypothesis that the distribution is normal. So and the alternative hypothesis, the distribution is not normal. So if the p-value is above 0.05, we will assume that the distribution is normal. If the p-value is less than 0.05, we would say it's not a normal distribution. If you look at the p-values on the data that I here, that you see all the p-values are greater than 0.05. So here you will say, at least based on the statistical test, the distribution is normal. Most important is to create a histogram. Histogram gives you a pictorial representation of your data. You can change the width of the bins for the histogram. Once again, if you put on Google how to do histogram on Excel, you will get a 5-minute tutorial from someone which beautifully shows how to create a histogram. And so in the histogram, you can see whether the data fits a normal distribution or not. Then you can also plot what's called a quantile plot. I don't want to get into what a quantile plot is, but if the plot is along this straight line, then you can assume that the distribution is normal distribution. So if we are looking at Pearson's correlation, what are the statistics that we need? We are looking for. We are looking for what's called the correlation coefficient, that is R. We are going to look at P, that's our P value, and we are going to look at R2, that's the determinant, coefficient of determinant. So these are the things that we expect the computer to output when we do Pearson's correlation. So as I said, R is the correlation coefficient, P is the probability value, the P value, R squared is the coefficient of determination. I'll go through them. So correlation extends from -1 to 1. It doesn't go, the correlation coefficient doesn't go beyond this number. So what does -1, 0, and +1 represent? Well, if we'll start with when it's 1. When it's 1, it means that there's a positive correlation. As the x increases, the y increases as well. So this is a full correlation with a coefficient of 1. If the graph shows a horizontal line that despite that you increase the x, the y doesn't increase, then there's not really any association, then the correlation is 0. So when the correlation is 0, there's no association. When the correlation coefficient is -1, when the x increases, the y actually decreases. So it's an inverse relationship. There's an association, but the relationship is inverse. So the correlation ranges from -1 to 1, 0, having no correlation. If you look at this example of age of 12 people and their salaries, is there a correlation between age and salary? So first of all, I'm using again the DataTab software. It automatically, when you press the button to do the test, it automatically does all the 3 tests of assumptions. It does all the statistical tests. Here you can see the normality tests are all above 0.05. So we can assume based on the statistical says that it's a normal distribution. Looking at the histogram, it kind of gives you a normal distribution. You might have to use your imagination, but certainly it's not a flat one. And if you look at the QQ plot or quantile plot, once again, it's pretty much going along the line. So if with these all 3 being in agreement that the data is it has a normal distribution. And once again, same for the salary. We do this, the software does the statistical test, the histogram, as well as QQ plot. You want to then again also, before you do any statistical test, as Dr. Riz said, you want to put the data on a graph and get a visual impression how the data is. So for correlation, you want to put it in a scatter diagram or scatter plot, and here the age goes up, salary goes this way. You see it's not flat, and you can see some sort of trend going upwards. So once you know that, once again, that plot is again DataTab automatically plots it. And before you do the Pearson test, you have to figure out what's your null hypothesis and what's your alternative hypothesis. Null hypothesis is that there's no correlation between age and salary. So the null hypothesis, the line is going to be flat. The alternative hypothesis is that there's a correlation between age and salary. So if the p-value is greater than 0.05, you will say that there is no correlation, because that's what the null hypothesis is. If the p-value is then less than 0.05, then you will say the null hypothesis is rejected and it supports the alternative hypothesis that there's a correlation association between age and salary. So if you do the Pearson correlation on that data that I showed you, then what you see is a correlation coefficient of 0.68, and you get a p-value of 0.015, and a coefficient of determination is 0.46. The R-square is basically produced by squaring the R. So R by R gives you the R squared. So if we first of all look at the correlation coefficient, you remember I said it ranges from -1 to 1, and a coefficient of 0.68 by convention falls into this group where it's highly correlated. So if the coefficient is between 0.7 to 1, then it's very, very highly correlated. When things are this correlated, you want to check the data that there's not some error in it. And if it is between 0.3 to 0.5, it's medium correlation, 0.1 to 0.3, low correlation, and 0.1 to 0, no correlation. It also works the same way if you go to the minus. If it is minus 0.7 to -1, then it's very highly inversely correlated. This diagram is from DataTab as well. So now we'll look at the p-value. We said the p-value from this output was 0.15. That is less than our alpha, the level that we said would be the threshold for statistical significance is 0.05. So because the p-value is less than 0.05, we reject the null hypothesis that there's no correlation, and we support the alternative hypothesis. There's a correlation between age and salary. So what we are saying is that the fact that if we look at previously that the correlation coefficient of 0.68, because the p-value is less than 0.05, that is a valid coefficient of correlation. So now we look at the R2. R2 is, you remember, it's the squaring of R. What the R2 says is that it gives us what's the variability of one variable to another, how much does it account. So because the R2 is 0.46, what it says is that there's a 40%, so the age accounts for 40% of the variability of the salary. So other 54% are to do with other factors. But as people get older, they earn more because there's a confounding variable that they are also having more experience. But what this R2 is that it tells you how one variable affects the other variable. But if you put it the other way, that 40% of in correlation, it works both ways. You assume that the association goes both ways, but sometimes it doesn't make any sense. If we say that 46% of the age can be accounted by salary, you know that the age can't be moved. It doesn't matter how much you earn, you can't change your age. So you have to be careful. It doesn't matter what numbers it gives. You always have to think to yourself, ask yourself, is the results meaningful? But usually correlation works both ways in terms of how one factor influences the other factor. So whenever you are doing statistics, nowadays the software are so easy. Pretty much, you will be able to. If I show you, you will take about 5 minutes to figure out how to do the statistical test on a computer. But you need to be sure that all the assumptions are actually met. The first assumption is that the sampling, those 12 people that I took, was a random population. It was not that I went to some expensive golf club and took 12 people from there. It should be a random sampling. And for this one, you have to definitely have, for correlation, you have to have pairs of data. If there's one data not there, then you can't use that set. And also it has to be from a single population. This is what I mean by that. It shouldn't be that you get a data from males and then you get a data from females and then you combine. It has to be from a single population that you are looking at. And the data should come from independent observations. So you can't look at 12 people and how their salary and age is, and then you go to a family with the 3 brothers, and 3 of the 12 are from the same family, because families have that they have how much each member of the family earns has a bit of a relationship. So you have to be careful that it is all independent, not from certain subgroups. The assumption 5, I hope I haven't jumped is that the X values are not used to compute the Y value. So what I mean by that is that, let's say if you are looking at if you are looking at the correlation between motor scores and GCS, obviously the total GCS is made up of motor score as well. So you can't use when one factor is actually derived from the other factor, you can't use those data for correlation. And also correlation is from observation. They are not from controlling. So if I increase the X, then look at the Y, then that will go to regression. But if if you are doing experimentally moving, let's say that you are increasing the temperature in a room, and then you are seeing how much the rat runs around, then what you are increasing the temperature 1 by 1 by 1, and that one you can't use for correlation, because then the R2 and the P values don't make much sense in a correlation. So for that you have to use regression. And also for correlation, if you're going to use Pearson's, then the data has to be Gaussian distribution. There's a bit of controversy. If you look at different books, they say only one has to be Gaussian, but I think it's safe to say that it's better to have both variables to be normal distribution. Otherwise, you should use Spearman rank correlation. And also you have to look at the data to see, actually, are you expecting a linear relationship? If there's a linear relationship, you can use correlation, but the standard correlation. But if you think that the relationship is U-shaped, then using a correlation which assumes a linear relationship will not be appropriate. And also you have to be careful that looking at the data, there are no outliers, because outliers tend to pull the data towards them, and it makes the correlation coefficient, the p-values, all skewed by these outliers. So if there are outliers, you need to see whether these are real outliers, whether you can correct for these outliers by either taking logarithm and normalizing the data. But it's important that you don't have outliers. What are the common mistakes when you do correlation? When people say correlation, they sometimes think it's causation. If you look at the amount of chocolates the Swiss eat and the number of Nobel Prizes they have won, you will see that both are correlated. But that doesn't mean that the Swiss are getting so many Nobel Prize because they are eating chocolates. So you have to be careful that correlation is an association, but it is not a causation. And the second mistake is that to look at the p-values, to put too much emphasis on the p-values. What the p-value says is that the line is not flat. So you might have a p-value which is 0.005, but your R and the R2 are like very small, like let's say 0.1, that only 1% of the influence, Y is influenced by only 1% by X. So although the p-value is high, the actual R and R2 are so small that they don't have any clinical significance. So while p-value is important, more important is the correlation coefficient and the R2. And once again, you shouldn't do any statistical tests. I know I have done it, but it's a bad practice you have to always look at the graph. And that's the nice thing about both. Most software usually gives you both graphs when you output graphs and the statistics. But the nice thing about DataTab is that it gives you the graph and then at the very bottom and gives you the statistics, and it's easy to look at. But please have a look at the graph before you do statistics. So what happens if the data that you are looking at is not normally distributed? They are the distribution is non-parametric. They don't fit that beautiful bell-shaped curve. Then what you need to use is called Spearman correlation. It doesn't use the actual number, but what it does is that it ranks the age, the person with the least age, number 1, the second least age, number 2, third least age, number 3, and ranks the age and then ranks the salary and bases the statistics on the ranks rather than the actual number. The results of them are very similar to in terms of the correlation coefficient, R2 and p-value. They are pretty much the same, but usually you can also use Spearman's correlation for parametric, but the results are not as strong as if you use a normal data, and it's better to use it on Pearson's, and if it's non-normal data, then use it on Spearman's correlation. But if you are going to use Spearman correlation, you have to look at the data and make sure that the relationship is monotonic relationship. What do I mean by monotonic? Monotonic is that if the X is increased, the Y has to be increasing as well. Or if the X is increased, Y has to be decreasing as well. When it's not monotonic, is that when you increase the X, it initially goes down, then goes up, then comes down. That's not a monotonic. If it is monotonic, then you can't use Spearman's correlation. So what happens if you have a Glasgow coma scale or an ordinal scale or some other, let's say the Chiari outcome scale? Then if you are going to compare, then you have to, rather than using Pearson's or Spearman, you need to use Kendall's tau. And you can use Spearman's correlation as well, but when it's an ordinal variable, one of them is ordinal variable, Kendall's tau is better for doing correlation. So in conclusion, for correlation, decide whether the data is continuous or ordinal, decide whether the data is parametric or not, choose the appropriate test, Pearson's, Spearman, or Kendall tau, look at graphs, and check that the assumptions are satisfied. Now I'm going to take you to linear regression. So linear regression, you need to, it's a very fascinating story because the word regression is hard to understand. Why did they use regression for regression? Basically, Sir Francis Galton was born in Birmingham. He was an extremely clever guy, but like all those people at that time, had lots of biases, including eugenics. But what he looked at was that he looked at the children of aristocrats and children of working class people, and parents and aristocrats and their children, and the working class people and their children. He figured out that if people are tall, then their children are usually shorter. And if the people are short, then the children are usually taller than the short parents. So by this, that through time, what happens is that the average, they usually approach to the average. So regression, so he termed the regression to mean. And this caused a lot of anxiety. So all the aristocratic people started to worry their children are going to end up being average. And obviously it hadn't worked out, but the word regression comes from that initial concept, regression to mean. So regression, as I said, you have to, first of all, you have to assume there's a model. And here in this one, I'm going to say that, I'm going to cover this, the linear regression, simple linear regression that assumes the relationship is linear. That's the model. You can explain it by I'm sure you remember from your school days, y is equal to mx plus c. If so, that can, you can draw a line, and then you can fit that line to these data and then use that line to predict the other results. And if it's U-shaped graph, then you will use a quadratic equation. As I said, if the graph is like a sinusoid, then you will use a sine-based formula. So you have to have a model, you have to assume for a model. So with linear regression, what it allows you is that not only it tells you how y is influenced by x, but it also allows you to find for, if let's say that this is the concentration and you have got the data for the various concentration, but let's say if I want to find what's the y going to be at 0.55, then I can look up the graph and figure out it. So what it allows is that it allows you to interpolate. And the interpolation is because you are going to fit a model, and in a linear regression is y is equal to mx plus c. And whereas y is obviously y is not the gradient, m is the gradient, y is the outcome, and c is where the line crosses the y-intercept. So in linear regression, you are going to use continuous variables, age, weight, distance walked, time, and concentration. So these are the linear variables. So in a regression, what you want to get out of your calculation, your statistics, is the gradient of the slope, where the line cuts at the y axis, the y-intercept, and what's the confidence interval. So here you have got the data, and now we have fitted a straight line that is what's called the, which has the least squares. I'll show you in one of the next slides. So here so what we are doing is we are fitting a line on the data to try to explain using a linear relationship. And also you want to have a 95% confidence band. So for example, so here this data point was from this data. But if I want to find out what's at 21, then according to the graph, I go from here 21, come here and look at the y. But then I need to know that y could be actually from here to here. So that's the nice thing about having a confidence band as well. So, but you have to understand the confidence band in a linear regression is usually curved. And the more the samples that you have, these confidence band gets closer to the straight line that you have, you consider to be the best fit line for these data. So this is an example. This is an example that I got from a book called Intuitive Statistics. This is the author of the book is the same person who developed GraphPad Prism. I will certainly, so most of my talks are based on that book. It's a beautifully written book. It's detailed, but not much mathematics. It really explains this nicely. I will put it in the chat box, the name of the book and the author. So this is X and Y. This is the lipid, the unsaturated fat in the cell membranes of muscle, and this is the insulin sensitivity of those muscles. And so they both are continuous variables. And first of all, what you call, when I use the DataTab, it automatically plots it, and it gives you that, linears like this. This is non-linear. You can see the data can fit a linear model. So this is done by that one. So when I say the least squares, so this is called this is the line that you are going to fit, and the distance from the line is called a residual. And what the correlation does, it finds a line which has the least sum of these residuals, squares of these residuals. So this is because here this is less than the this point, it will be negative. So if you square it, that gives you positive. So you square all the residuals, you sum it up, and the best fit line has the least amount of residuals from the line. So that's the basis of a simple linear regression. The second assumption is that the residuals, these residuals are actually normally distributed. Once again, in DataTab, it does the test for you. You don't have to do another test to find it out. So it makes your life easy. And if you look at all the p-values here, the p-values are greater than 0.05, so the residuals have a normal distribution. And the third assumption is that no correlation between residues in different part of the graph. So if you say this is the residues, that what it says is that there's no correlation between these and these. These are all very independent. And for that, you do something called a Durbin-Watson test. Once again, for that test, you with DataTab, it automatically does it for you and gives you a textual explanation as well. Once again, the p-value for is greater than 0.05. So that means that we can reject the hypothesis that there's correlation between the residues. So once again, so that's the third assumption we are happy with. The fourth assumption that we had to be sure before we do regression is that it's what's called homoskedasticity. That means that if you draw the line, the points above and below have the same distribution all along the line. For example, if there's no homoskedasticity, or that then you call heteroskedasticity, then if you draw a line, you see there's the distance from this line here is this much, but as you go further away, the distance increases. So if you have that relationship, then you can't use a linear regression. You either have to try to change the data using logarithm to see whether it fits a normal normal distribution, these points. So you have to make sure, and once again, this is done in DataTab automatically. So here, DataTab outputs where if you look at these points along the line, this is a line, not the line of the best fit, but this is the line that they'd say forecast versus residual. There's pretty much equal on either side, not like the heteroskedasticity as the distance goes, as the x-axis increases, the spread doesn't increase. And then when you have the linear regression, the software usually does all the calculations and fits the line, and it gives you a slope that's 37.21 and the y-intercept, and so this data I got from the GraphPad Prism. And so if we know the slope, the gradient, and if we know y-intercept, then we can draw the line. And what does it mean? So I said to you earlier that the slope is 37.21. So that slope is the m, and the c, where it cuts the y-axis is this one, minus 866.5. So using this formula, now you can plug in 22 here, and so it's 37.21 multiplied by 22 minus 486. Then that will give you the predicted y. So now you have created a line, you know the equation of the line. Now you can use that line to interpolate. So if you work within the range to find out a y in this range, then it's called interpolation. If you go outside the range of the data and try to find the y, then it's called extrapolation. Extrapolation is not so wise because you don't know how the data goes beyond it. And the p-value is important as well, because in the p-value here is less than 0.05. And so what it says is that the slope the slope is more than 0. So what it says is that there is a regression, there's a relationship. It's not a flat line. If the p-value is greater than 0.05, then our null hypothesis, the slope is 0, would be the correct. But because the p-value is less than 0.05, we reject the null hypothesis and we say there's a significant slope, a non-zero slope. And once again, the one good thing about the GraphPad Prism is that they give you a lovely confidence interval band, which the DataTab doesn't do. And once again, it also gives you the R2, the determination. So R2 here is 59.59, that's 59. So 59% of the variation of Y can be accounted by the X. And whereas 41% has to be accounted, 41% of the variation in Y is accounted by other factors. So it's important to have the R squared as well. So I'm going to quickly go through the assumptions. The assumption has to be that the model is linear. Then only you can use a linear regression. Otherwise, you have to use a non-linear regression. This is why I said you can't extrapolate. You can interpolate within that range, but if you can't extrapolate, you don't know how the relationship goes beyond that data. And once again, you have to make sure that X and Y are not intertwined. So if, for example, if you are looking at the correlation between the midterm exam results and end of exam results, where the end of exam results incorporates the midterm results, then you can't use that for looking at regression, because Y is already derived from X. And you need to know X values precisely. You remember when I said correlation, you are observing, but for regression, you want to you want to change the X, and you want to know exactly what the X is. And then know the Y. Then only you can be confident with your p-values and the coefficient that they are true. So in terms of comparing correlation to regression, in correlation, you can switch the X and Y axis and it really doesn't matter. But in regression, you can't switch the X and Y axis. You have to decide before which is the dependent and which is the independent and which is the dependent, which is influenced by which. And R2 is the same for correlation and regression. The common mistakes are not using regression, a linear regression, when the relationship is not linear. And then if you use smoothing of data, so let's say that if you are looking at from 1950 onwards, whether the storms in Caribbean is increasing, and so then you collect data for number of storms every year, but then you decide that what you are going to do is for 1960, you are going to add the last 5 years in 1960 and then divide it by 5 and then give 1960 that number. You are trying to smooth it. I think there are places for smoothing data to see a better trend when the data varies. But certainly if you do smoothing in regression, it doesn't work. As I mentioned earlier, that you don't want to have data which are intertwined with each other, that one is derived from the other, like motor scores and GCS. And as I said earlier, you have to decide which is Y and which is X. You have to always look at the graph, not just the statistics for normal distribution. And as I said, you can't. If you are going to, you can interpolate within the data that you had to look at a particular data set that was not in your data, but you can't go beyond the data to extrapolate. And you also have to, once like correlation, you have to be careful in interpreting p-values. If the p-values can be small, but if the R2 is small as well, then it means that the effect of X on Y is so small that it doesn't matter the p-value is small, the relationship is not significant. The line is almost flat. So yeah, use linear regression when the data are complete with no sampling errors. Data from the population is used. So another thing that you have to be careful is that for example, here this is the data that you plotted for males, and this is females. Here you don't see any relationship, but once you combine them, you get a linear relationship. So you have to be careful that you shouldn't combine data from two groups into one group when you do regression. So in conclusion, if you understand linear regression, then you will then easy to understand multiple regression, and the most important regression in medicine, surgery, is logistic regression. But if you have a good understanding of linear regression, you will understand them. And regression is a very, very powerful technique, because it is the regression that many times that you find out what factors cause diabetes, age, sex, the amount of weight, height, the shoulder girth, the abdominal girth. So for those, you use regression, and usually you use logistic regression. But if you have a good understanding of linear regression, easy to understand logistic regression. One of the areas where linear regression is used in neurosurgery is to look at how many papers they produced when they were residents, and how many papers when they were produced when they become faculty, whether they are, say, a correlation, and subsequently whether they are, say, regression. So thank you very much. I hope I have stopped the presentation. Thank you. If you have any questions, please put it on the chat box. Otherwise, we will move to the next presentation. Is from Dr. Ghaith Hbbaoub. He's a consultant neurosurgeon from the famed clinic, Cleveland Clinic. He's a spine neurosurgeon. His interest is on machine learning and artificial intelligence. I read an interview with his chairman, Dr. Steinmetz, about 2 years ago, when Dr. Steinmetz took over from Dr. Benzel as the head of the department. And Dr. Steinmetz said that for him, when he looks at residencies nowadays, he looks not at how many papers that they have produced, but how much experience and how much they have produced in the information technology and on artificial intelligence, because they are going to dominate in the next short term to medium term the progress. So Dr. Hbbaoub, thank you very much. Looking forward your talk on this, this very important and area that I find a bit more complex, survival analysis. Thank you.
Well, thank you very much for having me. Yep. So my talk will be on survival analysis. Okay. No disclosure related. Sorry, let me make sure. Okay. So the objective is to understand why to use survival analysis, and also learn the tools used in survival analysis. And the contents, what I have here in the slides are, first one is why use it, and what is censoring, talk a little bit about a Kaplan-Meier curve, we'll talk about a little bit of the survival function and how to calculate it, and how to compare two survival distribution, how to measure some contribution, and we'll do a brief review on code, how to generate some of that information. So why do you want to use it? So some of the questions usually been asked that, time to event analysis, or the other name for survival analysis is used for, is something like, what is the proportion of population surviving past a certain time after some sort of intervention? What is the average survival time, usually after some intervention? Does surgical treatment improve survival? And what factor influence survival over time? So this is kind of the question where time to event analysis or survival analysis is used for. So some of the examples here, usually you want to have a start time and an end time for a study. And during that period of time, you have a patient who comes in, so that's where the beginning, and then they develop or not develop an event. That time can be a variety way. Can you do it in days, weeks, months? Doesn't matter, whatever you define it. One example you can look at, looking at mortality following spinal cord injury, and look at it in the period of years. You can look at the ambulation following metastatic cancer to spine and treatment and some intervention. We can look at this by month. You can look at spine surgery and return to work. So it doesn't always need to be a negative outcome, right? It can be a positive outcome, and you can look at this week. And we can even look at non-even patients. So you can look at the wear that happened, disc arthroplasty, and look at this in years. So when you have some sort of starting time and some sort of defined event and a time, and usually some sort of associated with intervention, usually that's all you need to do the time to event analysis. So you really come to the question, to me at least, is why not just use the regression that you just eloquently described in the last lecture? And the difference here then in a simple linear regression is we have a concept of censoring, and that's kind of what makes the whole field of time to event analysis a little bit different. And the reason is, and so what is censoring? Censoring, let's say we have a study, want to design a study. Well, there's already well-designed study on this topic, on looking at outcome following intervention on metastatic cancer to the spine and looking at ambulation. So let's say we have a patient during that period of time, and then after a period of, initially when they come in, they were ambulating, you do the intervention, and then a while after, they lose their mobility. So that's what we call as an event happened. That's where the X is, you can see on the top left. So that's the first patient. So that's great. That's what we're looking for. But then there's a lot of situations where we don't have that information, which makes survival analysis important. But if all patients had that information, there is no all observed information available, then probably you can go around, do a different type of time-based analysis and avoid this censoring concept. But unfortunately, most studies, there's a lot of censoring. So a second example is you do the study and you finish the study, but the patient never lost ambulation. Well, it doesn't mean that they will never lose it, but what it means is we just don't know. Like, let's talk about the extrapolation. We just don't know after the period of time if they will lose the ambulation. Other situations, loss of follow-up. So maybe a patient travel outside, the country, out here to Paris, and then we don't have any information on the patient. And what do we do with that information? Do we ignore it? Well, you can, but then we might have our analysis a little bit biased. Or do we take that into account, but only take the information up to the point, information collected, and make some assumptions? And other situations, a different event happened. So what if I'm looking at ambulation, but a patient died? What do you do with that? I guess the patient's not ambulating, but does not mean we reach the event that we're expecting it to reach. So because of all of these, the time to event analysis kind of creates some tools that we can use to help us understand this picture. Some of them is the Kaplan-Meier, that's kind of most famous. It's a very nice graph that we can look at and interpolate here information from the data. So what do you do basically? So that's an example of some sort of post-intervention survival following some sort of cancer. And you can see you start with the x-axis here, you have the time, and the y-axis, you have the probability of survival. So everybody at the beginning are alive, and then we lose people along the way. So you start with 100%, and you can go down, sometimes go down to 0, or sometimes not. And that what dictates that is the censoring. So if you go to 0, then everybody reached the event. But if you don't go to 0, then there's some censoring happen. And that's kind of where the advantage that you only get with these type of analysis, you don't get it from another, that some addition of censoring to the graph, to the information you collect. So for example, here, let's say we're looking at 4 months. We want to see what's the probability of surviving after 4 months of intervention. And we can see here, if we draw a line on the x-axis to 4 months, and when we see the y-axis correlates, that on the figure is 0.6 or 60%. So we can make that estimation from the figure. There's a few concepts, briefly go over them. just to give you like a little bit perception of how you look at this. It's almost like you look at it in two different ways on the same concept to some degree. So when you look at survival, you look at how many people survived after in a period of time, and that's what they call survival function, SFT here, where they have the probability of survive after a given time point. But you can look at it from the event standpoint. That's what they call the hazard function, HFT. So that's a risk of an event happening at point in time t. So we're all talking about the same thing. We just are looking at who's left or who's having the event or incident. And then, while it's nice to look at one point of time, usually we look at cumulative information, up to that point in time or from that time forward. That's where the cumulative hazard is just adding up stuff. And you can see, you can imagine there's one is some sort of relationship between one and the other. And yes, the survival function and the cumulative hazard is linked. So just a little bit example of just how to create a Kaplan-Meier. And this is a bad way of doing it, but just give you like a kind of decomposing a problem and turn out to be a little bit simpler than it sounds. So let's say you have your data needs to be for a simple Kaplan-Meier curve. All you need is, the patient and the time to event. Here we assuming everybody reached the event. We'll talk about in the second one. Not everybody reached the event. So if you look at the graph, it's going from 0 to 1 or 0 to 100%. So everybody reached the event because they all dropped to 0. So the way you do this, and a little bit tricky to do it in Excel, which I did here. But all you need to do is define these time points where the event happens. So, you always start with 0. So we'll put that at the beginning, and then we'll see like the first, here's all ordered. So the first patient reached the event at 3 months, and 4 months, 6 months, and so on. So we put these into that table. That's kind of the survival table on the right side of the Excel table. And then you just calculate a few information. So the M here is how many events occurred at that time point. So, at 3 months, only 1. At 4 months, there's 2 patients, or that's 2, and so on. And then you calculate the survival function by simply dividing the N number over total number. But that's assuming everybody reached the event. Now you can look through a line, but the way we look at Kaplan-Meier is we look at stepwise graph. So you can have a little bit tool to help you create a stepwise, or you can just draw it. It becomes a little slightly more complex when you have a censoring. So here there's 3 patients never reach the event. You can see patients, I think 4, 9, and 13. And the way I know, because I have a column called censored, and 0 is when they didn't reach the event. There's slight modification in the analysis where the M, you don't take basically into the calculation the censored, and you just I add the prior values to that point of time. And you can see here the calculation. I'm not going to go over details, but the concept is pretty much the same. And then from the survival function, you do pretty much similar calculations. We'll slightly a little bit complex here, where is it the product from the N minus M of the current multiplied by the prior. So it's a little bit more recursive logic there. And you can see here, as opposed to the prior graph, this one did not reach all the way to 0 because there's 3 patients that are censored. So, it's not that complex to get there, and obviously nobody will do that on their hand, but you can see that relatively easy to translate from data to the graph if we just have the calculation right. But that's one way to look at the data. So Kaplan-Meier is what we call non-parametric. There's been a lot of talk about parametric and non-parametric. Took me, to be honest, a long time to figure out what does it even mean, parametric, non-parametric. And non-parametric pretty much is, there's no assumption about the data. What is the data? I'll probably sort them, do something with them, but I'm not going to assume anything. I'll just use the data, create something out of it. when parametric is rather you're describing usually some sort of distribution. For example, you say, well, these data look like normal distribution. Meaning, okay, well, what are the parameters of normal distribution? There are two, mean and standard deviation or variance. Here, so you can see here with different variances and different means how the normal distribution looks different. The way I think about it is from back when I was studying this is from information theory. Is like when you are trying to communicate information, let's say I have data and I'm trying to explain it to you guys about what are the data giving us information. So one way I can say, oh, here's the data, look at it. That's definitely one way because I communicate all the information to you. The other way I can abstract it into some sort of a distribution and say, well, look, you know, the age in my data was 50 with a variance of 20. And I can just communicate that information. There's a lot more condensed information. These are parameters of the distribution of my data. So instead of sending the whole data, I'm just sending that information for communication. So a lot of that information comes with the information theory to some degree. But parametric does not mean normal distribution. There's a lot of distributions. Interestingly, some of them are used to do some stuff with survival analysis. So you have the exponential and Weibull. So exponential, well, I might have exponential think about going up, but usually it's going down the other way I think about it. But when you obviously accumulate, that's the probability density function, it's trending down. But when you look at it over time, it's obviously accumulating over time. But so the exponential curve, you look at it with the Kaplan-Meier, it's like, oh, well, it looks a little bit similar to some degree. Like I can maybe imagine fitting these dots to like exponential distribution. That's why it's a little bit useful. Weibull is a little bit more advanced. When you have a little bit more fluctuation in your analysis, you can add additional parameters. So exponential is a single parameter. So normal distribution, 2 parameters, mean and variance. D-distribution, 3 parameters. Exponential, 1 parameter, is called lambda, is like the cousin of mean. The Weibull tend to be 2 parameters. And that's what parameters mean, is some sort of information within the distribution that tells you the whole thing about distribution without need of the whole data. Kaplan-Meier, you need the data. You need normal distribution, exponential, Weibull, logarithmic, and all these distribution, you can just get 2 numbers and you know exactly what we're talking about. Now, that's for talking about the Kaplan-Meier, but what if we, okay, well, now we have a Kaplan-Meier of one intervention. What if we have information about 2 groups? So, for example, the famous study, the Patchel study, which is from the study, this figure where they're comparing the surgery plus radiation to radiation alone to an outcome after metastatic cancer. And this is the figure where all patients started being were ambulating. This is kind of the subgroups. And we're trying to see, here I kind of selected random dates at 1 year, how many of the patients continue to be ambulating at that point in time. And again, you do exactly what we did before. We go find on the x-axis the time, you draw up line, see where it's crossing, and go on the y-axis. On the radiation alone, it was 25%. On the radiation plus surgery, where it was 40% people who can continue to be ambulating after 1 year. That's great. Like, I mean, we can extract that information, but the question comes all the way down in statistics because it's a sampling problem. Is that important? Is that significant? Like, did we figure out the difference between the population that whatever we did here explained by the figure? And that's where the question usually comes: is there a significant difference between the 2 curves when it's comparing 2 distributions, survival distribution? And the answer to that usually use something called the log rank test. And what that does is compare the distribution of the time until an event, not even an event occurs, of 2 or more independent samples. So pretty much describing exactly what you said. Some sort of 2 groups here: surgery, plus radiation, and looking at their survival distribution. Is that different or not? And same as everything in statistics, you saw null hypothesis. So I said, no, there's nothing distribution are the same. You're not, you're kind of overreading information. So it's always easy to negate a problem as opposed to prove it, because there's many ways to prove something and only one way to negate it. So that's kind of some of the concept of statistics in general. So the way it works, you have that data, you do the log-rank test, you get an output of p-value, and you'll say, is it greater than 0.05? If yes, you retain the null hypothesis, and we'll go that these two distributions are the same. If not, then you'll say, well, you reject it, and you might approve the alternative hypothesis, which is there is a disparate distribution. So if you look at the partial study, for example, and I'll just read from the study, encoding here. In the subgroup of patients who could walk at study entry, 94% in the surgery group continued to walk after treatment, compared with 74% in the radiation group. Patients, and that's a p-value of 0.024. So the first thing is 94%, 74%. Where did that come from? So they said at study entry. So if you can kind of squint a little bit and send immediately after 0, where's that landing? And you'll notice it's somewhere around 94 and 74% in the blue and less blue curve. And so that's where these two numbers. And then you say, like, where's this p-value? Well, that p-value could be easily obtained from the log-rank test, and that's what the purpose of looking at the whole two distribution and saying, well, these are different or not. That's if you kind of want to design a study and kind of provide the information. In a different way, I can say, instead what they wrote down there, I can say what we just said, where at 1 year, where it's 40% of the patient continue to be walking, and in the surgery plus radiation group versus radiation alone was 25% with a p-value of this, obtained from the log-rank. And you can see the p-value here is not exactly on the exact numbers there, but rather with the distribution. But it's still I think scientifically acceptable to say give like a 1 point in time, because it's difficult to say. I'm not going to say every single time point what's the difference in both, but kind of get the spirit out of the distribution with these two numbers, and then while they are different distributions. All right, measure contribution. So the second question we can try ask is, well, especially maybe not in two groups, but I just come to a figure here, but does age influence the outcome? They might imagine, well, maybe, some patient or offered surgery or younger or something like this, or so they might have influenced the outcome. Well, maybe the way you check this is regression, and kind of there's a good follow-up to prior lecture where is a variation of the regression here, and not a simple linear, but rather using exponential function, which is what's called a Cox proportional hazard survival regression. Very long name, so they just shrink it down to Cox regression. But you can see here, relying more on the hazard. But again, you're almost like the two faces of a coin. One looking hazard, the other by survival. If you look at survival, the other hazard. So one gives you a picture on the other to some degree. And the Cox regression, the point of it is determine the influence of different variables on survival time. There's actually never really heard of DataTab or whatever it's called before. Kind of interesting that seemed like a very useful tool. That being said, they have a very good YouTube series on some of these information, and it seems like the output from these analysis are very condensed and meaningful. So this is actually a snapshot from the YouTube on the Cox regression. So what you can see here, they included two covariates, if you want to call it, on the regression. One is the treatment, and the other is age. And you can see they look at the p-value here and tell you the p-value is significant, less than 0.05. What that means is there's some sort of important contribution of the treatment type on the outcome. The age seems like less. Now here, coefficient, you have to be a little bit a grain of salt, because there's an exponential function. There's not like I talk about linear, where say like, 5 age plus, there's 5 times the age. So there's all that makes it a little bit difficult to just use the number there to make like a simple statement. So I would not use that. I would just probably at least rely mostly on the p-value to describe if they're significant or not. The last thing I was going to go through is a very brief example using the information we talked about, kind of 3 main big things, and see how we can create simple figures. We can make the figures a lot prettier, but you can make, I pretty much use R myself for statistics. I don't use it for other stuff, but for statistics, I use R. And unfortunately, you have to code with these, but it's not as painful as might sound, especially when you are doing a very specific task on a well-defined template. So if you know how the data should look like, then pretty much as long as you run the exact code on that data, you get the same outcome, at least the output. So for example, here, this is an open, in R is open source, so it's free. And this is an open source data set on prostate cancer. You can see the sample data sets on the bottom, in different patients, treatments, 2 types, time to event, so you have it there, and the status where 0 is event happened and 1 is censored. We have some other covariates, including age, size of tumor, and so on. So what we can do is create a Kaplan-Meier curve, and you can see we have the confidence interval, 95%, the dotted line. That's pretty much similar to what we talked about. You can see that there's some patients censored, so it's not reaching all the way to 0. And you can do a little bit more fancier stuff, including log rank test. So if you look at the treatment, there's difference in the outcome based on the treatment, and the p-value 0.3. So it says it curves. We accept, we cannot reject the null hypothesis here, and so we say there's no significant difference between the 2 Kaplan-Meier distributions based on the treatment. And the last thing, we can try to do the Cox regression, and in using pretty much the same style of writing regression in R, if anybody's familiar, which is that tilde sign and pluses. So we would say the survival function is dependent on these stuff, treatment, age, size, and so on. And then you do a summary, and you get a bunch of p-values, and pretty much most of them are not significant except for a couple. But then start talking here is something like the age contributing to some sort of survival more than the treatment, and based on the p-value in the last column in the analysis below. So that's kind of definitely one way of doing in R. There's a thing like a DataTab, or a lot simpler to do it there as well. And if anybody have questions, they can email me on my email. Thank you.
Thank you. Thank you very much, Dr. Hbbaoub. That's a really useful presentation on survival functions. I find it difficult. It's not, when you try to do it on an Excel sheet, you have to quite start to understand it, and when you try to, and I always found it difficult, so it's really good to have your talk. I've gone through it, I'll go through it a few more times as well to get a good feel for it, so thank you very much. If there's any questions to Dr. Hbbaoub, please put it on the chat box, or please email it to Dr. Hbbaoub. Dr. Hbbaoub, once again, would you be happy for your presentation to be, certainly it's recorded, but to be put on the web as a PowerPoint presentation as well?
Oh, absolutely. And I can share these slides as well if that's of interest.
Oh, that would be great. Thanks. And I can put it on the web as slides. We have now come to the end. Before I thank participants and the faculty, a few things to mention. At the very end, I'll post the the link for the certificates. Once you put please on that form, let me know whether you will be interested in attending a workshop, a weekend workshop where you can have lectures, then work through problems and discuss about how designing. You can then have exercise on designing a project and looking at statistics for it. So please let me know. We'll find somewhere sunny. I just want to show you the data tab and the GraphPad Prism to show how easy those softwares are. And I have also posted on the chat box the name of the book and the author, The Intuitive Biostatistics, and also that I should be able to show you the listserv statistics center. So let me just share my screen, and I'll take you to the and this is, I'm going to take you to DataTab. Okay, so this is, in terms of doing regression. So let's do correlation with the DataTab. And so usually when you start, go to the website, what you call, they automatically put you, this is a different example data. So what I will usually you can clear here I put my own data, but I can clear it and I can put the example data. So you see there's usually an example data. So when you have example data, you then can figure out how you put your data into it. Then if you look in the very top, you can see what kind of variables is it nominal. If you want to change it, then you can click and change it, but it's auto, you can click and change here, but on the top you can see whether metric or continuous or nominal data. Then if you come to the bottom, then it gives you the different tests. So I want to do correlation, and I want to look at the correlation between salary and age. Okay, so I just click there. Then I'm going for Pearson's. You can choose which one it is. If I will say Pearson's, and the alternative hypothesis is correlation. And then it gives you a default p-value of 0.05. And then the amazing thing about this one is that usually you have to test for every assumption. But here, if you click that, it has already tested to use the statistics to test for the normality, histogram, the QQ plot for both variables as well. So you see that's quite, and then in your data, in your results, you can say these were tested. And then it gives you the R value, the P value. The only thing is it doesn't give you the R square, which you can easily multiply by itself and get the R squared. I have written to the developer why they haven't put R squared. Then it gives you the data on the diagram. You can save it as a PNG file, and you can change the settings if you want to change the colors. If you want to put a regression line, you can put a regression line. You can change the sizes. And then it gives you an explanation about all aspects of it, each one by one. And also in terms of so here you see that the p-value and the R is 0.68. So that's, good correlation. P is less than 0.05. But the other nice thing is that it gives you a summary in English, what all that means, and then also puts the reference table as well. So you see how it's pretty much takes you by the hand. And so that's the data tab. Just before I switch over to the GraphPad Prism, I just wanted to show you that this is this is the Neurosurgery Study Design and Statistics Center I set up back in 2017. So if you want if you want any questions or want to discuss about study designs, feel free to post it. Obviously, if someone is helping, they have to be credited, but you can have a look through it. And if you want any help, please look at it. So I'm just going to stop it and then take you to GraphPad Prism. Let me just take you there. Share. make sure that's open. Yeah. Or for keeping, I got it. Sorry. So this is GraphPad Prism. I hope you can all see it. And this is the opening page. And here it gives you various tests, the columns. And once again, you can click to start with the samples. Okay. And the nice thing again about samples is that what you call, you now know where you need to put your data to replace that sample data. So if you go to survival, if you want to compare two groups, you start with the sample data and then creates that. And then you can, this is the dates elapsed, this is the control, this is the treated. There are some explanations here. And you can replace these with your data. Okay. It automatically, then what you do is you go to analyze, click here, and then you say simple Kaplan-Meier, A and B, okay. And, you pretty much click through, and then it gives you all the p-values for the log rank and the other hazard, mental and hazard ratios, log rank as well. And it also gives you a graph. And you see what I'm trying to say is that it's kind of a, you have the, to when you get started, if you go to Excel, you need to have quite a good idea what you are doing from the very beginning. Here you can learn as you go through, and actually you will find it's quite useful software. So as I said, I haven't tested, I certainly know GraphPad well. I haven't tested DataTab to the full, but if you have a choice, I will say go for DataTab. Otherwise, and it's cheaper as well, for 3 years, $99, and it's very, very smooth. Whereas with the GraphPad, which was the best, most user-friendly software, it is now superseded by DataTab. But if you have both of them, it certainly helps. But the nice thing about the DataTab is that you might be at work, you might be anywhere. You don't have to have your desktop because it's all on the web. So thank you very much. I hope that was useful. I'm just going to put the website for the feedback form. So in the feedback form, please complete just basically your name, your email address, just to put it twice, because sometimes people get their names wrong or the email address wrong, and any comments, as well as whether you will be interested in the workshop. So it leaves me to thank the esteemed colleagues, the faculty, for taking their time at the weekend to teach us. And I will make sure that give me some time. Certainly the YouTube is already recorded. You can go and look at it. I will also put the PowerPoint slides as well. And I really thank all the participants for coming. It shows you obviously shows your commitment to research, commitment to improve your knowledge, commitment to study research papers more insightfully. So thank you very much all, and look forward to seeing you hopefully in some sunny place for a workshop. Wishing you a nice weekend. Take care. God bless you. Bye.
Thank you. Thank you, Naren.
Thank you very much. Thanks a lot, Elias. I'll leave the screen on so you can have the chat box, and you can then click on all the links for your phone. Thank you. Take care. Bye for now.